Hello everyone, very warm welcome to all of you guys. Myself, Dr. Vaibhav Jain, and today we will be discussing about the most important questions that can be asked from microbiology as well as dermatology. Okay, please let me know if I'm clearly audible and visible so that we can proceed with the session, guys. Good evening, good evening. Good evening, Kavya, Doc, Ishan. Yes, so audio video is fine so that we can proceed with the session. What I would be doing, I have incorporated all the important PYQs, all the important topics that has been asked in your examination. Okay, so we have gathered all the important information and I would be giving you this information in the next subsequent hours. Okay, you have to be very active with me. We try to be interactive with me. Okay, till the end of the session you will be learning multiple things and I'm sure you will be getting a lot of marks from this particular session. Okay, at least 10 marks you can get from this particular session. Okay, 10 marks I'm guaranteeing, right? So let's start with the session. Yes, good evening, Sadia, Mega. Let's start with the session, guys. Let's, without any further delay, these are my Instagram and Telegram. In case if you are having any doubt regarding the session or questions, you can definitely reach out to me. Okay, next thing, which type of microscope can be used to detect the motility of the probable causative organism? So the question number one, which type of microscope is used to detect the motility of the probable causative organism in a truck driver? Remember guys, NMC or NBE, the most important question, they are always obsessed with the truck driver. Okay, so they are asking this question multiple times. Presenting with a painless indurated genital ulcer. The patient is having painless ulcer. Okay, the patient is having painless ulcer. Okay, painless ulcer. Which of the following would be the method of diagnosis? How you will diagnose? So today we are having approximately 100 questions that would be incorporating 50 to 60 questions from microbiology and 40 questions from Derma. The topic itself, right? I would be teaching you the topic itself. Okay, so first of all, make the diagnosis, guys. I want you guys to make the diagnosis. So what is the diagnosis over here? So this is a case of syphilis. Very good. This is a case of syphilis. And syphilis, what is the causative agent for syphilis? Class will be till at 8 p.m. The causative agent for syphilis will be Treponema pallidum. Treponema pallidum is the causative agent, and remember it is a spirochete, guys. It is a spirochete. Okay, it is a spirochete. It is a thin bacteria. It is a thin bacteria. So those bacteria which are not easily visible, those are thin bacteria. We are using what? We are using which kind of microscopy, bacho? We are using dark ground microscopy. We are using dark ground microscopy. Dark ground microscopy we are using. Okay, so that is your dark field microscope we can use. Where do we use electron microscope? Electron microscope, remember the images will be black and white. Okay, so you have seen about the viruses. Okay, electron microscope was discovered by, try to answer. You will be having black and white image. Okay, light microscope was discovered by Sir Anthony von Leeuwenhoek. Okay, that was the normal microscope. Light microscope, the question that they will ask you on the power. Okay, so we are having scanner, we are having low power, we are having high power. On the question they will ask on the basis of power, and we are having oil immersion field. Scanner will be 4x, low power will be 10x, high power will be 40x, and this one is your 100x. Okay, the maximum magnification we can get is there any issue with the audio? Just a moment, let me make it clear. I think audio is fine now. Audio is fine now. No issues with the audio now. Okay. Okay. Let me adjust the mic. I think it's better now. Perfect. So we are having these things. We are having light microscope, we are having electron microscope. In electron microscope, you will be getting a black and white image. First thing, the question that they have asked you on this particular thing, low power will be 10x, high power will be 40, and lastly we are having oil immersion field, that would be your 100x. Okay. What is a fluorescent microscopy? Remember guys, in central institutes like AIMS, you know what happens, there is a multiple patients are coming, a lot of patients are coming, so there will be very much load of the patient, so we cannot run diagnostic test for every patient. Okay, so in that case what we are doing, we are doing screening, we are doing screening testing, and the dyes that we are using, we can use fluorescent microscope. Okay, in fluorescent microscope, look here, what are the things that we are using. For example, you want to diagnose malaria, what is the dye that you will be using? Try to answer. For malaria, for TB, what is the dye that you will be using? And for fungus, for malaria, we will be using acridine orange. We will be using acridine orange, guys. For malaria, we will be using acridine orange. For TB, we will be using rhodamine or amine. Rhodamine or amine. So for example, a patient is coming to us, lots of patients are coming to us. What we will give, we will give the slide to the patient that will be having already this fluorescent dye. Okay, now what will happen, this fluorescent dye will be passed through UV light. If it is coming positive, then we will send the patient for diagnostic test. Okay, next one is about the fungus. The fungus that we are using is calcoflower white. Calcoflower white is the dye that we are using for fungus. That is the dye that we are using for fungus. Till now what you have seen that this is the case of syphilis, and in the syphilis is a painless genital ulcer. Okay, now we will be discussing about the different kind of ulcer. Can you identify, can anyone tell me what is this ulcer? Because in the OPD, when you are going to sit in the OPD, what will happen, the patient will directly come to you and he will directly show you. You need to identify what is this type of ulcer. We will be understanding everything. Okay, so what is this type of ulcer, what is this type of ulcer, what is this, what is this? If the patient is coming to you, he will just open up the organs and he will be telling that I am having this kind of thing. How you will identify? How you will identify? So remember guys, if you know the terminology, life will be easy. Okay, so we are having this thing is herpes. This thing is herpes simplex virus. Just remember simple thing. Herpes, the meaning will be, the मतलब क्या होता है herpes का? Herpes का मतलब होता है, मतलब is simple grouped vesicle. The meaning of herpes will be grouped vesicle. And what is a vesicle? Vesicle is a clear fluid filled lesion less than 0.5 centimeter. Okay, we will be discussing about that. Okay, so these are multiple grouped vesicle. Can you appreciate? These are your multiple grouped vesicle. Answer will be herpes. Okay, so first of all you need to see whether the ulcer is single or ulcers are multiple. Okay, so first of all you need to identify. How you will make the diagnosis? Just look here. First of all you will see whether the ulcers are multiple or single. First thing you will look for, ulcers are multiple or single. If ulcers are multiple, there can be two possibilities. Either it can be herpes simplex virus, either it can be chancroid. Either it can be herpes, either it can be chancroid. How you will differentiate? Sir, the meaning of herpes, you already told us that meaning of herpes will be grouped vesicle. So herpes will be having this type of grouped vesicle. You will be finding multiple grouped vesicle. Okay, this one is the chancroid. This one is the chancroid, guys. It will be having undermined edges. Can you appreciate? This ulcer is having undermined edges. Terminology is important. If you understand this, your question will be right. Okay, मजा आ जाएगा क्वेश्चन करने में. Next thing, this chancroid will be having unilateral painful buboes. Two things you have to remember: unilateral painful buboes and undermined edges. That would be your chancroid. Okay, so these are the two types of ulcer. Multiple will be two. Both of them are painful ulcer. Okay, if they ask you about single ulcer, okay, single ulcer can be having two possibilities. Either it can be ulcer of syphilis, either it can be ulcer of donovenosis. कैसे आइडेंटिफाई करना है? यू नीड टू आस्क द पेशेंट मल्टीपल अल्सर है, सिंगल अल्सर है. यू कैन सी if the ulcer is single, look here, if the ulcer is single, it will be of syphilis, right? It will be of syphilis, either it can be of donovenosis. How will you differentiate? Remember, donovenosis ulcer, they will be having a characteristic appearance that would be beefy red appearance. Beefy red appearance. If you are finding beefy red appearance, your answer will be donovenosis. Okay, syphilis will be having single ulcer. Syphilis will be having single ulcer. Look here, syphilis will be having single ulcer. But if in the option it is written bilateral rubbery or shorty lymph nodes, that would be your syphilis. That would be your syphilis. How many types of syphilis do you know? Try to answer, guys. How many types of syphilis do you know? So this is how we are differentiating. So basically we are having 5 types of ulcer. First of all, we need to identify whether the ulcer is painful or painless. Okay, so painful ulcer will be 2. First one is your herpes, second one is your chancroid. Herpes कैसे identify करोगे? How you will identify? Herpes will be having grouped vesicle. Herpes, simple thing, you will be having grouped vesicle. Remember guys, herpes का मतलब ही grouped vesicle होता है. Herpes zoster. What is the meaning of herpes zoster? Zoster means what? Along a nerve segment. So you will be having grouped vesicle along a nerve segment. That is herpes zoster. Simple, right? Next one, this one is your chancroid. Chancroid is due to do cry. So do cry, the patient will cry, and this is a painful ulcer. This is a painful ulcer, right? Syphilis will be, syphilis is painless. Syphilis is painless. It is caused by Trypanosoma pallidum. You will be finding what kind of lymph nodes? You will be having rubbery or shorty lymph nodes. Okay. Here in due cry, just remember, you will be having unilateral painful buboes. Okay. Donovenosis due to Klebsiella granulomatis, and you will be finding single beefy red ulcer. And lastly, LGV. Sir, LGV to padhaya hi nahi. Why I have not discussed about LGV? Because this is a transient ulcer. This is a transient ulcer. That means till the time patient reach the hospital, this ulcer will be gone. There will be no ulcer, right? So patient jab tak aayega, koi ulcer nahi hoga. So you need to make diagnosis between these 4. Okay. So one is herpes, second one is chancroid, third one is syphilis, and lastly we are having donovenosis. Syphilis के ulcer को क्या बोलते हैं? What do we call the ulcer of syphilis? That is known as chancre. And chancre is painless. Remember, chancre is painless. That is how we can remember. Okay, done guys? Okay, now we will be discussing about the treatment itself, and then we will be solving the question. Okay, so first of all, try to discuss about the STD kits, because these kits are coming in your PSM also, in your microbiology we are discussing, in your dermatology STD part. Okay, so what are the kits that we are having? We have to remember, first one is your any kind of discharge that is coming from urethra. Look here, any kind of urethral, anorectal or cervical discharge. Urethral, anorectal or cervical discharge, there can be only 2 possibilities. What can be the possibilities? Either it can be a gonococcal urethritis, it can be due to gonococcus, either it can be due to chlamydia. 2 possibilities हो सकती है. Okay, it can be due to gonococci, it can be due to chlamydia. For gonococci and chlamydia, the drug of choice that we can use over here is your azithromycin and cefixime. They would be taking care of both the things. Okay, so first thing, any kind of urethral, anorectal or cervical discharge, that would be treated with the help of azithromycin or cefixime. Second thing is your vaginal discharge, any kind of vaginal discharge. Vaginal discharge can be due to 3 things. Okay, either it can be due to fungal infections like candida, it can be due to bacterial vaginosis, and one more that you study is that would be giving your strawberry vagina. What is that? Try to answer. That is your Trichomonas vaginalis, right? So for bacterial vaginosis and Trichomonas vaginalis, we can use metronidazole or we can use sakinidazole. Okay, and candida is a fungal infection, so we need to give antifungal, that is your fluconazole. Done guys? Okay, now we will be discussing about the ulcer. Okay, patient is coming to you with genital ulcers. First thing, non-herpetic means what? There will be non-grouped vesicle. If the patient is coming, so what can be the possibilities? What we have seen? We have seen, sir, only 3 things can be happening. either it can be chancroid, either it can be syphilis, either it can be donovenosis. Okay, so here either it can be chancroid, either it can be syphilis, either it can be donovenosis. The drug of choice for syphilis will be, try to answer guys, drug of choice for syphilis will be, remember guys, primary syphilis, secondary syphilis, early latent, late latent, tertiary syphilis, or neurosyphilis. Every syphilis, the drug of choice will be penicillin. The drug of choice will be penicillin. Drug of choice will be penicillin. Okay, so for syphilis we are using penicillin, and for chancroid and donovenosis we can give a drug that is azithromycin. Okay, next, if someone is allergic to penicillin, then we can shift the patient to doxycycline. Okay, doxycycline. Next is your genetic again ulcer, that is your herpetic ulcer. Herpetic मतलब क्या होगा? The meaning of herpetic means they are grouped vesicle. If you are seeing grouped vesicle, multiple grouped vesicle, directly jump on to the diagnosis of your herpes, right? Here what we are giving acyclovir 400 mg. Remember guys, in herpes zoster we are giving double dose, that is 800 mg. Okay, here we are giving 400 mg. Okay, then we are having lower PID pain in your lower abdomen, right? What we can suspect, it can be due to bacteria, so we are giving antibiotics. It can be due to amoebic infection, so we can give metronidazole, or we can also give doxycycline. Okay, inguinal buboes if given, then the drug of choice will be azithromycin, or also we can use doxycycline. So these are the 7 kits that you have to remember. Sequence will be green, sequence will be gray, green, white, blue, red. That is the sequence of WBR is the sequence of, this is the sequence you will be finding in which phenomena? You will be finding in which phenomena? Try to answer. White, blue, red. This is the sequence you will be finding in which phenomena, guys? In Raynaud's phenomena. Raynaud's phenomena. Okay, Bicho? Now try to solve this particular question. Okay. Try to solve this particular question. A young woman arrived with, look here, a young woman arrived with vaginal itchiness. A green frothy discharge is coming from her genital. During the examination, a condition known as strawberry vagina was observed. Okay, so strawberry vagina has been observed. Which medication would be considered the most suitable in this particular case? What is that? Very good, Sindhu, Shobna, Lone Bilal, Ankem, Priyanka, Sadia. Okay, so what is the drug of choice that you will be using over here, guys? You will be using what? So strawberry vagina is due to Trichomonas vaginalis, Trichomonas vaginalis, and the drug that you will be utilizing here will be metronidazole. Okay, doxycycline, all those things we are not using, guys. Okay, what we will be using? We will be using metronidazole. Okay, can anyone tell me which kit will you give? Very good, Megha, Sadia, Patel, Twinkle, Shobna. Okay, which is the kit that you will like to give to this particular patient? In case if you want to give the patient the kit, try to solve this question. The following lesion is seen in 25-year-old men who came to a primary health center 5 days ago after having a unprotected sexual intercourse. On palpitation, the ulcers were painful. Painful ulcers can be two etiology. Either it can be herpes, either it can be chancroid. Okay. Suppurative inguinal lymphadenopathy was present on the right side. Unilateral inguinal lymphadenopathy. Your answer will be, guys, your answer will be, first try to make the diagnosis. What would be your diagnosis? The patient has no previous history to drug allergy. Which kit will be given for this particular patient? Here, try to answer this particular question, guys. What is red? Try to make the diagnosis over here. What is the diagnosis over here? Remember two things. Painful ulcer is there. Painful ulcer is there. Painful ulcer is present. Second thing, unilateral. Remember, guys, unilateral painful lymphadenopathy. Remember what I've told you. Here in the ulcer, you will be finding what? In the ulcer, you will be finding what? In this type of ulcer, First of all, make the diagnosis. What is the diagnosis? Don't directly jump on the answer, guys. We are learning new things, okay? We are learning how to solve the question so that we will not make these mistakes in the examination, okay? So we are just making the diagnosis first. First of all, you need to make the diagnosis. Painful ulcer can be two situations. First one is your herpes simplex virus. Second one is your chancroid. Chancroid is due to Haemophilus ducreyi, right? You will be having undermined edges. That is what we have discussed. You will be having undermined edges and multiple painful ulcer, okay? So for chancroid, what is the kit that you will be using? What is the kit? Look here, guys, what we have seen. Kit number 3, that is the white kit. White, where is yellow? Kit number 3, kit number 3. Kit number 1 will be urethral discharge, any kind of urethral, cervical, anorectal discharge. Kit number 2 will be vaginal discharge, and kit number 3 will be genital ulcers, genital ulcer. Kit number 4 will be genital ulcers which are allergic to penicillin, and kit number 5 will be ulcers which are having we will be using acyclovir, that means herpetic ulcer, and then we are having lower abdominal pain only, and lastly we are having inguinal buboes. Clear, guys? Understood? Try to solve this particular question. A 22-year-old college girl has a history of sexual exposure with a commercial sex worker. There should be a male, right? Student, right? Now presenting with a painful genital lesions. The patient is presenting with a painful genital lesions. Painful, I have told you, two things can be there. Painful can be either it can be, sir, herpes simplex virus, either it can be chancroid. Only two possibilities can be there. Either it can be herpes, either it can be chancroid. Okay, and lymphadenopathy, again, right, inguinal lymphadenopathy is given. What would be your answer? What would be your diagnosis? Everyone, you guys are not understanding or what? Try to answer, guys. What would be your diagnosis in this particular case? Very good, Sadia, Dr. A.M. Sindhu. So that would be chancroid. Chancroid will, remember, guys, what I have told you. I have told you painful ulcer will be two. One is herpes simplex virus. Second one is your chancroid. These are the painful. Painless will be syphilis is painless, and second one that we are having is donovenosis. Donovenosis, what would be the history? You will be finding beefy red ulcer, beefy red single ulcer, beefy red single ulcer. That would be your donovenosis. Wonderful, guys, wonderful, wonderful. You guys know everything, right? So question number 1 is done. Are you guys understanding? Is this the right way? Okay, now we will be discussing about the question number 2. What is the question number 2? Question number 2 is DNA transfer in bacteria. DNA transfer in bacteria via phage is known as, what do we call it? Is it a conjugation? Is it a transduction? Is it a transformation? Is it a translation? How the bacteria will be having transfer of DNA? Why, sir? Why it is important? The reason being, nowadays antibiotics are getting resistant, right? So these are the reason. Because of that, antibiotic resistance will be transferring from one person to another, right? So DNA transfer in bacteria via phage. Very good. LGV patients will be having painful buboes only, okay? Painful buboes will be there. There will be no ulcer, okay? There will be some complications. We will be studying in the detail. You will be finding histamine and all those complications will be there, okay? Groove sign is positive, all those things will be there, okay? You need to study in detail. So this is about the DNA transfer in bacteria via phage. What is a phage? First of all, try to answer what is a phage. Phage is a type of virus, okay? It is a virus. So it is a virus which is infecting the bacteria. Viruses are infecting everyone, but it is a virus which is infecting the bacteria, that is known as phage. What is the most common method of transfer of resistance? The most common method, if you say, that is your conjugation. How conjugation will occur? Remember, in the bacterial anatomy or physiology, you will be seeing two things. One is flagella, another one is pili. The function of pili is formation of what? Formation of sex cord. The function of pili will be formation of sex cord, whereas the function of flagella will be movement. Function of flagella will be movement, right? So what will happen here? Look here. The most common method of resistance transfer, if I ask you, that is the Formation of sex code. This is the sex code. Look here, this is the sex code. What is happening? The information is going from one cell to another, and this is via sex code, and this is the most common method of resistance transfer. This is the most common method of resistance transfer. Okay, second one is about the transformation. Transformation means what? Here the bacteria will be taking up the free DNA. Look here, this is the free DNA, fragment of DNA taken up by the bacteria, and they will be incorporated, right? This is known as transformation. And thirdly, transduction is like abduction. मतलब क्या हो गया? Kidnapping होगी, right? So transduction is because of bacteriophages. Look here, the bacteriophage is coming, ये अपना DNA अंदर डालता है, it will be making certain copies, and they are going to infect other bacteria. So this is the transduction. Okay, this is the transduction. So transduction most commonly seen in Staph aureus. This was the previous year question they have asked you. Most common method of transduction in Staph aureus. That is why we are having MRSA. Remember, we are having MRSA. What is MRSA? Methicillin resistant Staph aureus. So methicillin is not working now. Okay, so after that we have developed, what is the drug of choice for MRSA? Tell me guys. We are using vancomycin, right? So but the bacteria has converted himself into MRSA. Now that is vancomycin resistant Staph aureus. So we are giving linezolide, or we are also giving daptomycin and linezolide we are using, right? So this is what is happening. This Staph aureus is a nasty bacteria. Okay, most common resistance transfer, if I ask you, your answer will be conjugation. Okay, if I ask you the question in Staph aureus, most common method of resistance transfer, your answer will be transduction. If I talk about Streptococcus pneumonia, most common method will be transformation. Clear guys? Transformation. Okay, wonderful guys. Now try to solve this particular question. Sporulation occur in which phase of bacterial growth curve? The answer for this particular question will be transduction, which is basically abduction. Okay, try to solve this. Sporulation occur in which phase of the bacterial growth curve? Sporulation, what are the different phases? What is the life story of a bacteria? Bacteria will be having lag phase, bacteria will be having log phase, bacteria will be having stationary phase, and then the bacteria will die. Okay, then the bacteria will die. So let's look here. This is the growth curve of a bacteria. First phase that the bacteria having is your lag phase. In lag phase, what you have to remember? You have to remember there will be increasing in the enzymatic activity. Just remember, A will be coming first, so lag will be coming first. Lag phase is the first phase. Okay, then there will be log phase. Log will be, what will be happening? Here you will be finding maximum activity of the bacteria and maximum number of division. This is important. Maximum number of divisions will be occurring in which phase? That is log phase. Okay, then come the stationary phase. You can remember the mnemonic, that is stab. Okay, so in stationary you will be having sporulation, bacteria will be making the spores. Okay, T for toxin production, bacteria will be making toxin. A for antibiotics production, and B for bacteriocin production. Okay, bacteriocin production. Okay, can anyone tell me what is bacteriocin? Okay, so bacteriocin production is there. Okay, last phase that we are having is decline phase. In decline phase there will be death of the bacteria. So these are the four important phases. Two options you have to remember. One is maximum number of division will be occurring in which phase? Your answer will be log phase. Then stationary phase will be having STAB. S for sporulation, T for toxin production, A for antibiotic production, and B for bacteriocin production. Guys. Okay, now try to answer this question. The stain used to identify Cryptococcus is, what is the stain that we are using to identify Cryptococcus? Cryptococcus is a bacteria or what? Cryptococcus is a bacteria or what? And what is the disease that the Cryptococcus is causing? What is the disease that is due to Cryptococcus fungus, right? What do you think? What would be the answer, guys, over here? Everyone is going with C, B, A. So can anyone tell me how many types? So this one is causing in HIV positive patient, remember guys, in HIV positive patient, it will be causing meningitis. So it will be causing meningitis and HIV positive patients. Okay, so we are having different types of stain. Let me explain you what is India ink stain. You must not have studied about it. So we are having simple staining. What is simple staining? Simple staining, same color will be given to all the bacteria. For example, I can use methylene blue. So all bacteria will be blue in color. I can use basic fission. What will happen? All bacteria will be. Is it fine now? Is it fine now? Is it fine? Audio is okay now? Okay, so we are having simple staining. In simple staining, we are having methylene blue, we are having basic fusion. Okay, we are having methylene blue, we are also having basic fusion. Okay, second thing, we are having negative stain. What is negative stain, bacho? Audio is not fine. No audio is coming. Is it fine now? Okay, so its second one is your negative stain. Negative stain, what we are doing, we are staining the background. Guys. We are staining the background. Let me just. In second one, we are staining the background. I think it would be better now. Better? Perfect. Okay, so in negative stain, what we are doing, we are staining the background and the bacteria will shine up, right? The bacteria will shine up, and the examples that you have to remember is your one is nigrosin. Second, you have to remember is this one. This is your India ink stain. So for Streptococcus, we are using India ink stain. Those who are answering C is right answer. Okay. Third type of staining that we are having is impregnation staining. What we are doing, we are adding silver. For example, I need to see flagella. For example, I need to see flagella. We already know flagella is a very thin structure. So what I will be doing, I will be adding silver to this bacteria. Now what will happen? We are having two stains that we have to remember. One is Livardity, another one is Fontana. Livardity and Fontana. Remember, Livardity is done for the tissue sample. Fontana we can do for fluids. So those bacteria we cannot see. We are putting impregnation staining. We are basically adding silver to the bacteria. Okay, and what will happen? Silver will be giving always black color. Silver will be giving black color to the bacteria. That is how we can see. And lastly, we are having differential stain. Whatever options are left, they are the differential stain. That would be differentiating between two bacteria. First one is your Albert staining. We are using for Albert staining used for diphtheria. Okay, bipolar staining. Bipolar will be giving you safety pin appearance. Multiple bacteria are there. And Zn staining we are doing for TB like organisms. Okay, so we are having this thing. Okay, so answer will be C, Indian ink. Okay, one more thing, remember this one is done for the CSF sample. For tissue sample, we will be doing tissue sample of Streptococcus, we will be doing mucicarmine stain. Okay, mucicarmine stain. Try to solve this one. A 3-year-old child present with fever. The symptoms are given here. The patient is having fever. Which one you want to know? You can rewatch the video. Okay, Harsh, you can rewatch the video. So we are having fever, we are having loose stools, we are having blood in the stool. Okay, which enrichment media is used to isolate the organism from the stool sample? First of all, try to make the diagnosis what they want to know. Yes, all the important medias are covering in a single slide. In the next page, we are having all the culture medias. Okay, don't worry about that, doctor. Okay, everything is here. A 3-year-old, just be with me till the end of the session and everything we will be covering, right? A 3-year-old child present with fever, the patient is having fever, loose stools means what? The patient is having some kind of diarrhea, and whenever the diarrhea is having blood or blood is along with the diarrhea, we call it dysentery. And the most common cause of dysentery we can recall is Shigella. And the culture media that we will be using for Shigella will be what is the media? Enrichment media that we will be using for Shigella will be selenite F broth. That is selenite F broth. Remember, Shigella or Salmonella. Remember, Shigella and Salmonella are twin sisters. Okay, they are both twin sisters. The culture media will be same. Okay, can anyone tell me RCM we can use for what? RCM, Robertson cooked meat media, we will be using for RCM. We will be using this particular thing for Clostridium. We will be having two important species, Clostridium perfringens. Remember, perfringens will be causing food poisoning. Okay, and Clostridium tetani. Tetani is a proteolytic species. Okay, that would be causing what? Tetanus. And remember, tetanus is a 100% fatal disease. Rabies and tetanus are 100% fatal disease. If someone is having them, they will be gone, right? So that is the tetanus, and both of them are vaccine preventable diseases. Okay, so you can prevent them, right? Alkaline peptone water we will be using for Vibrio. We will be using this particular thing for Vibrio. And Vibrio, what kind of diarrhea will you see? Remember guys, in Vibrio you will be having two questions. One is from physiology, that is it will be binding with GM1 ganglioside. It will be binding with the toxin of Vibrio cholera will be binding with GM1 ganglioside. And second question that you need to remember about Vibrio, you will be having what kind of stool? That is rice watery stool. Okay, rice watery stool will be there. Okay, next, brain heart infusion we will be using for fastidious organisms like meningococcus and pneumococcus. Okay, so your answer will be C over here. Very good guys. Sadia, Meher, Tanya, Medicophil, very good. Okay, so these are the culture medias. All the culture medias are incorporated over here. Let's see one by one, fast we will be revising so that we will able to answer, right? The important one that you have to see, first one that we are having is Staph aureus. The media that we are using for Staph aureus is mannitol salt agar. Remember, staph, the meaning will be what is the meaning of staph? Staph means bunch of grapes. The meaning of staph will be bunch of grapes will be there. Aureus, AU is gold, so you will be having golden color colony. Okay, you will be having golden color colony. Strepto will be Streptococcus pyogenes, that would be a crystal violet blood agar. Enterococcus, wherever you are sitting, just try to speak with me. Staph aureus, MSA or Ludlam's media. Second one is your Streptococcus pyogenes. Pyogenes will be crystal violet blood agar. Okay, next one is about the Enterococcus, that is bile esculin agar. Neisseria will be Thayer-Martin. Okay, Neisseria will be Thayer-Martin. One more is there, New York is there. Okay, next one is your MTB, that is Lowenstein-Jensen media, LJ media. Bacillus anthracis, I would be teaching you, that would be a plate. Okay, Clostridium, Robertson cooked meat media. Diphtheria, we can use Loeffler serum slope. We can also use potassium tellurite agar. Okay, next we are having nocardia. Important is nocardia, we are having paraffin bed technique. Listeria, we are using Palcom agar. You can remember, we can also do a test, that is Anton test. You can remember, Lisa Auntie Palcom Bazar gayi. Okay. Next one is your E. coli. We are using clad. Okay, clad and McConkie. So clad we are using. We can also use eosin methylene blue. Shigella, Salmonella, twin sisters. We are having selenite F broth. Vibrio cholera, that is TCBS. Okay, TCBS. Okay, Pseudomonas is a nasty bacteria that will be growing in the disinfectant. That is your Cetrimide agar. Okay, Bordetella pertussis, Bordet, Gengu, Regan, Lovi, all those medias for the Bordetella. Important one that has been asked in your examination is Legionella. So remember BCA Legionella. Okay, you can remember like BCA Legionella. It is concerned with centralized AC system. Okay, next one is about the Leptospira, red urine, all those things, paddy fields. So Leptospira, EMJH. Okay, Mycoplasma will be Eton and Puplo. given a question based on etone. Okay, Borrelia will be Calis media, Trypanosoma will be triple N, and Campylobacter will be Skirrhos media. Skirrhos media. These are the important medias that you have to remember. These are the important medias that you have to remember, guys. Okay, I will send the PDF. You can see it later. Okay, in the group itself, right? Try to solve this particular question. This was based on sterilization. There are multiple questions in your past examination. You have to remember this. Okay, first of all, try to solve this particular question, guys. First of all, try to solve this particular question. Which of the following method is used to sterilize a glass petri dish? You cannot miss this type of question. Look here, guys. Sterilization can be of two types. We will be revising everything really fast. So sterilization can be of two types. One is physical, another one is chemical. Physical, we are talking about heat first. Okay, so I can use two type of heat. One is dry heat, another one is wet heat. Moist heat means what? That is steam basically. Okay, so dry heat will be hot air oven. What are the things that you need to remember about hot air oven? So we will be using syringes. Okay, your glasswares, your petri dish. Okay, your glasswares. Okay, we will be using swabs, cotton swabs. Okay, so these are the three things that you have to remember about hot air oven. What is the temperature over here? We will be keeping the temperature 160 degree into 2 hours. And the third question that they will ask you is about the Bacillus subtilis is the spores that we are using. Bacillus subtilis are the spores that we are using. Second thing, dry heat is your incineration. Whatever hospital waste you are having, anatomical waste, your beddings, okay, your anatomical waste, hospital waste, basically your beddings, all these things will be going into incinerator. It is a big machine. What is the temperature? They have asked you. Temperature is 1200 degrees Celsius. Okay, so basically hospital waste will be going here. That is your incinerator. Two things clear. First one is hot air oven. Second thing is incinerator using dry heat. Second thing about the moist heat, we are having three things. Either the temperature can be less than 100, temperature can be 100, and temperature can be more than 100. Three things. Okay, simple things. First one is about the pasteurization. So who gave the term pasteurization? Who has given the pasteurization? That is your Louis Pasteur. Okay, so pasteurization is given by Louis Pasteur. We are having two methods. Pasteurization is done on a daily basis on the milk, right? So we are having two methods that has been asked. One is Holder's method, another one is flash method. So what we do in Holder's method, we are holding our milk for 63 degrees Celsius into 30 minutes. We will be holding it for 30 minutes. Okay, in flash, what we will be doing, we are using 72 degrees Celsius into 20 seconds, and then what we are doing, we are decreasing the temperature to 13 degrees Celsius. Okay, then we are decreasing the temperature to 13 degrees Celsius. Okay, next one is your inspeciation. Remember guys, inspeciation, there is a question in your exam. Inspeciation is done for two medias. One is LJ media, second one is LSS. Now try to answer. LJ media is for what and LSS is for what? Okay, then you will be remembering. Okay, on 100 degree we are having boiling, but due to boiling, is there any possibility the spores will be dying? No, spores will not die because of boiling. So we need to boil for 3 days, 3 consecutive days. That is known as teen dilation. You can remember like teen din tak garam kar rahe hain. You can remember like that. Okay, so you will be using 20 minute 100 degrees Celsius for continuous 3 days. So that is your 3 days teen dilation. Okay, most important, the important one is your autoclaving. The temperature of autoclaving will be 121 degrees Celsius, 15 psi for 15 minutes. Okay, what are the instruments, what are the things that we will be using over here? What are the things? All the instruments, all the surgical instrument, you will be finding this pressure cooker type of machine. So all the instrument, all the medias, culture medias, your sutures, except one suture. That is the question. 2-3 question. approximately 6-7 questions in last 2-year examination from this particular topic. Okay, so we are having sutures. What are the sutures that we are not using here? This is your catgut suture. Can anyone tell me catgut suture is coming from the intestine of what? Cat or something else? Okay, autoclaving we are doing for all the medias. What is the exception? For those two medias we are doing inspeciation. One is LJ media, second one is LSS. For them we are doing inspeciation. We are doing inspeciation, and catgut suture is we are not doing that. Okay, next one is about the filtration. We are using filters, and the control that they have asked you is your Brevendimunas dimunata. Very good. That is coming from the sheep's submucosa. Very good, guys. You guys are amazing. Okay, so that is your Brevendimunas dimunata. Okay, next one is about the radiation, guys. Next one is about the radiation. We are having two types of radiation. One is ionizing radiation, another one is non-ionizing radiation. So one thing you have to remember from ionizing radiation, the control will be pumilase. It is looking like R, so control will be pumilase. And ionizing radiation we are using for which thing? We are using for catgut suture. Okay, catgut suture. 2-3 questions that we have learned right now, right here. One thing, LJ media, LSS media, we are doing what? Inspeciation. We are doing inspeciation. Apart from that, all other culture media, autoclaving. Okay, sutures, all the sutures will be going in the autoclaving. What are the sutures that are not going in the autoclaving? Then your answer will be catgut suture. Catgut suture, what we are going to do? We are going to do ionizing radiation. Okay, ionizing radiation. Non-ionizing radiation we are using in OT fumigation. Okay, this is what you have to remember. Okay, for gas sterilization, the control will be Bacillus globogi. Globogi is the control. Globogi is the control for this particular thing. Okay, this particular thing. Lastly, we are having these liquids, chemical liquids. We are having alcohol. Alcohol is basically spirit that we are using. So spirit se kya saaf karna hai? What are the things we need to clear with the spirit? One is your thermometer, and second one is your stethoscope. Okay, aldehyde, we are having formaldehyde. We are having 2% glutaraldehyde in the market, coming with the name of Sidex. Most of the scopes that we are using, like laryngoscope, most of the scopes are cleared with the help of this 2% glutaraldehyde, that is your Sidex. If I talk about phenol, we are having Dettol, we are having Lysol, and then in the halogen we are having iodine, we are having betadine, we are having tincture of iodine, we are having betadine. All these things will be there. Important one is sodium hypochlorite. This one is the important one. We are using for blood spills also. Okay, sodium hypochlorite we are using in the time of COVID-19 also, and we are also using this particular thing in the blood spills also. Okay, so this is what you have to remember. This is the basic table that you have to see just before your examination. These are the important points. Okay, most important points as far as this particular thing is concerned. Okay, general में से इसके अंदर से there are multiple questions they will be asking. Okay, so you have to remember this. Okay, in which of the following is the disk diffusion method for antibiotic susceptibility testing is applied? Try to answer this one. My dear doctors, please try to answer this one. And which of the following is the disk diffusion method for antibiotic susceptibility testing is applied? Dr. AM is telling B. Apart from them, all others, what do you think, guys? So what do you think? Is it KBDDT? Is it PCR assay? Is it broth dilution? Yes. So just try to understand what is AST. What is AST? Antibiotic susceptibility testing. For example, I am having some kind of infection. What I will be doing? I will be giving my some kind of sample. Okay, I have given, suppose I have given blood for the culture. Now what the microbiologist will do? He will grow that culture in which agar? Your answer. Try to answer which is the agar that we are using in the this particular antibiotic sensitivity testing. Okay, so basically he is growing my bacteria, whatever blood is there, whatever sample I have given you, for example urine culture, let's say I am giving sample for urine culture. Okay, now what will happen, this sample they will grow under a agar that is known as Muller-Hinton agar, okay. Now what will happen, they will try to put different kind of antibiotics. Okay, so these are the different antibiotics. For example, this is your Norflox, we are using in UTI, we are using Norflox, but nowadays what is happening, this Norflox is not producing any zone of inhibition. That means bacteria around this particular things are not dying, right? But look here, the bacteria around this particular things are dying, right? So this is, for example, nitrofurantoin, this is another thing, that I can use. Okay, so this is a nitrofurantoin, so this one is susceptible, after 3 days I will get my report, and in that report I will be getting that I am resistant to Norflox, but I am susceptible to nitrofurantoin. So I can change my drug, and my treatment will be different, right? So I will be getting corrected, right? So this is how this is the antibiotic susceptibility testing is happening. Okay, this is AST. Okay, and what is this method is known as, Kirby-Boyer disc diffusion testing. This is known as Kirby-Boyer disc diffusion testing. So 2-3 question you have to remember from this particular slide. We are using which kind of agar? The agar that we are using is Muller-Hinton agar. And the name of the test will be Kirby-Boyer disc diffusion testing. Okay, so this is the thing, right? Now try to answer, which layer of the skin is characterized by the presence of refractile granules? Multiple things we can check. We can check for any kind of culture. Okay, any kind of culture we can check. So first of all, guys, tell me what are the different layers of the skin. So we will be going from outside to inside, then we will be discussing this particular question, refractile granules. Till then, try to answer. So we are having outermost layer, that is epidermis, then there will be dermis, and then there will be hypodermis. So we are having epidermis, then there will be dermis, then there will be hypodermis. Between epidermis and dermis is the middle layer, above dermis epidermis, below dermis hypodermis, right? So between these two layers there will be a junction that is known as dermo-epidermal junction, also known as basement membrane zone. This is the normal story. Now we will be discussing about the layers of epidermis. Epidermis will be having 5 layers that you have to remember. These are the mnemonic is come, let's grab, I know you must be hungry, so come let's grab some burgers, or some people are grabbing some beauties, right? So come let's grab some burgers or beauties, whatever you want to grab you can grab, right? Cute ladies get smart boys, whatever you want to remember, just please remember the layers sequence wise. Okay, first thing, come is your stratum corneum, second one is your stratum lucidium, third one is your stratum granulosum, stratum spinosum. Stratum का मतलब होता है layer. The meaning of stratum will be layer. Okay. Lastly, we are having bachcho, that is stratum basal. Remember, guys, stratum spinosum and basal together are known as Malpighian layer. They are called as Malpighian layer. They are together called as Malpighian layer. Okay. Now see, what are the different things that we need to remember about these things? Okay, epidermis hoga, dermoepidermal junction hoga, dermis hoga, then there will be hypodermis. Okay, these are the different layers that we have seen. First of all, let's start with the layer number 1, that is your stratum corneum. Okay, what are the things that you have to remember? 2 important things I want you to remember. First is it will be having no nucleus. Remember, guys, nucleus will be giving which color? Whenever you will be doing H&E staining. In histology, what is the staining that we are using? We are using H&E staining, right? Hematoxylin and eosin staining. So nucleus will be giving which blue color, okay? So if the complete structure is pink, stratum corneum is pink, that means it is a absence of nucleus, okay? So there will be no nucleus. Second thing, it will be absent in preterm babies. It will be absent in preterm babies. So what will happen? The baby will have high risk of infection. The baby will have increased risk of infection The baby will have water loss, baby will have heat loss. Okay, these things can happen. Second layer is about the stratum granulosum. Can you appreciate? There will be some kind of granules will be present. You must be thinking like granulosum, some granules must be there, sir. Okay, what are the types of granules that we are having? We are having keratohyaline granules, we are having odd-line bodies, we are having keratohyaline granules, we are having lamellar bodies, odd-line bodies. Sir, what is the clinical importance? I don't want to know about this. So it will be making filaggrin. Filaggrin is basically filamentous aggregating protein. If this one is lost, what will happen? There will be a disease that is known as Ichthyosis vulgaris. Vulgaris means most common. Okay. Second one is odd-line bodies. If there is problem with the odd-line bodies, what will happen? Odd-line bodies will be secreting lipid. So it will be secreting lipid. If there is decreased levels of lipid, there will be a type of dermatitis that will happen. What is that dermatitis? You will be having hardening. You will be having dryness in the skin. You will be having dryness in the skin, and we call it winter eczema. We call it winter eczema. Winter eczema or astiotic eczema. We call it winter or astiotic eczema. What is the treatment? Sir, treatment, we can give lactocalamine lotion, we can give some kind of lipid, because lipid is not there. Okay, so this is what is important about the granulosum. Two things you have to remember. Two things I want you to remember from the spinosum part. One is it will be having most abundant cell, that is desmosomes. Desmosomes are most abundantly present in your stratum spinosum. Second thing is about the Langerhans cells. Langerhans cells. What is Langerhans cells? Langerhans cells are basically they are macrophages. Basically they are macrophages. Remember, whenever the macrophage will present on the skin, we call it Langerhans cells. If they are present in your liver, we call it Kupffer cells. If they are present in your brain, we call it microglial cells. If they are present in your kidney, we call it, what do we call it? Meningeal cells. Okay, in bones we call it osteoclast, right? So these cells will be having different names based on their location. Langerhans, you have to remember two things. One thing is about the Birbeck granule. You will be having Birbeck granules, and what would be the appearance? You will be having tennis racket appearance. Tennis racket appearance. You will be finding these increased levels will be in the histiocytosis X, okay, or Langerhans cell histiocytosis. Lastly, we are having stratum lucidium. Lucidium will be present on, just remember the thing that I am telling you, L. Look here, L. It will be present in not all the parts of the body. It will be present in your palms. It will be present in your soles, okay. So it will be present in your palm, and it will be present in your soles. So both of them are having L. So lucidium will be present in your palms and soles. Palms and soles. Okay, palms and soles. And this one is having the refractile granules. Refractile granules are feature of this particular thing. An examiner already know. If they ask you about refractile granule, you must be thinking granulosum must be having some granule. So here answer cannot be granulosum. The answer will be lucidium. Answer will be lucidium. Done guys, sorted, done. Okay, perfect. Now try to solve this question. Which type of cell in the epidermis are responsible for providing protection against harmful UV radiation? Harmful UV radiation. Wonderful guys, wonderful. Now try to solve this particular question. Which type of cells in the epidermis are responsible for providing protection against harmful UV radiation? Harmful UV radiation. Remember guys, there are 4 cells you have to remember in the epidermis. We have seen 5 layers. Now 4 cells we have to remember. The first one is about the melanocyte. Let me teach you what is melanocyte. Melanocytes will be making melanosomes. Melanosomes. It will be making melanosome, and those melanosome will be making melanin, and that melanin will be giving color to adjacent keratinocyte, that is 36 keratinocyte, and that is known as epidermal melanin unit. That is what you know, right? Now this melanin, the function of melanin will be protection. Remember guys, those people who are white are at a higher risk of having skin cancer. Those people who are white, we are having Fitzpatrick classification. Okay, those people who are black, those people who are having increased levels of melanin, what will happen? They will be having a less risk of having cancer. That is why melanocytes are helping against the UV protection, UV radiation protection. Okay, second thing we have seen, that is Langerhans cell, basically macrophages. Merkel cells are what? Merkel cells are type 1 slow adapting touch receptor. These are type 1 touch receptor, slow adapting touch receptor. They are present in which cell, which layer? They are present in your epidermis. They are present in your epidermis guys. Okay, so these are type 1 slow adapting touch receptor. Okay, so the answer here will be melanocytes. Okay, lastly we are having one more cell that is present in your skin, that is your keratinocytes. How many keratinocytes? Approximately 95% of the cells will be keratinocytes. And remember, two keratinocytes are binded together with the help of a thing that is known as desmosomes का function क्या होता है? It will be bind. Suppose this is a keratinocyte, this is another keratinocyte. They are binded together with the help of desmosomes. So whenever this desmosome is gone, what will happen? They will be separated, and these cells are known as acanthocytes. So we will be seeing under zinc smear. We can prepare the zinc smear and we can see, right? So this is the normal histological slide that you need to remember, because nowadays they are connecting the question with histopatho part as well, right? So what do you need to see? First thing, this is your stratum corneum. This is your stratum corneum. Stratum corneum, look here. It is devoid of nucleus. There will be no nucleus. There will be no nucleus. There will be no nucleus. So look here. This is stratum corneum. Can you appreciate any blue thing? No, there is no blue thing. That means it is a stratum corneum. Then there will be a layer which is stratum lucidium. This is stratum lucidium. Then there will be layers. Can you appreciate these granules? That will be having granules. These are known as granulosome, keratohyaline granules, Odlin bodies. Then we are having spinosome. Why do we call it spinosome? We are having some spine-like structures. Can you see? These desmosomes are binded together. Two keratinocytes are binded with the help of desmosomes, and they will be appearing as a spinosome. They will be appearing as a spinosome. Okay. Lastly, we are having stratum basal. There you will be finding melanin. Okay. Then there will be basement membrane zone. Then there will be dermal papilla. Now you will be asking, what is dermal papilla, sir? Look here, guys. Let me teach you. What is dermal papilla? The part of epidermis which is going into dermis. The part of epidermis which is going into dermis, that is known as rete and the part of dermis which is coming into epidermis, this is known as dermal papilla. This is known as dermal papilla. Very, very important, because we will be finding we will be looking at the DIF images. Okay, once you understand this particular image, everything will be easy for you. Life will be very, very sorted. Okay, so you need not to worry about anything else later part. Okay, so just try to understand it now here itself. So whatever part of epidermis, above will be epidermis, this is your dermoepidermal junction, below will be dermis. So whatever part of dermis which is trying to invaginate into epidermis, that is your dermal papilla. What is rete regis? The part of epidermis which is trying to go into dermis, that is your rete regis. Look here, guys. Look here. Let me show you. So this is the part of epidermis which is trying to invade into dermis. This is known as what? This is your rete regis. Here is the part of dermis which is trying to go into epidermis. This is known as dermal papilla. Understood, guys? Clear with this? Okay. So these cells we have already seen. This thing, remember, we will be discussing in the secondary skin lesions. These squamated cells, those cells which are removing from stratum corneum, these are known as these squamated cells, and they will be making scales. They will be making scales, any kind of scales like pityriasis rosea. The normal meaning of pityriasis is scaling. Pityriasis rosea, red scaling. Pityriasis versicolor, scaling will be there. Versicolor mean different color scaling. There will be hyperpigmented patches you will be finding. You understand the terminology, life will be easy. Okay, you are having stratum corneum. Okay, stratum granulosum, spinosum, basal, Meissner's corpuscle. Question from physiology. Meissner's corpuscle is a part of. Now you will be answering. We will be ending the controversy. Okay, you will be answering Meissner's corpuscle is a part of epidermis or dermis. It is a part of dermis. It is a part of dermis present in your dermal papilla. These are also touch receptor. This is basement membrane, and lastly we are having some capillaries. Okay, simple things. Two cells you will be finding in stratum basal. First one is your melanocyte. This is a dendritic cell. This is a dendritic cell. Can you appreciate? And second one that we are having is your Merkel cell. So Merkel cell is a part of epidermis. Meissner's corpuscle is a part of dermis. Question and okay. Okay, question is ended, right? Now we will be having these things. Okay, so whatever important points from these things I have incorporated, so you need to remember the important ones only. Okay, so I will be marking the important ones. We are having keratinocytes. They are ectodermal in origin, present in all layers. Keratin filament will be there. What is the important thing? What is the marker? That is cytokeratin 14. Cytokeratin 14 is the marker. Second thing is about the melanocyte. They are coming from which cells? That is important. Neural crash cells. They are present in stratum basal. Right now we have seen melanocytes are present in your stratum basal. They are dendritic cells. Okay. Then it will be secreting melanosome. Melanosome will be secreting melanin. That would be giving color to adjacent keratinocytes. Okay. The markers, very important markers, guys. We are having first one, that is your Milan A. Milan A is the most important marker. We are having HMB 45. We are also having S100. Okay. Melanin, the function will be protection from UV rays. It will be imparting color to the person. Okay. Langerhans cells, they are mesodermal in origin because they are phagocytic. I've already told you they are macrophages, right? So they will be phagocytic in nature. They are present in your stratum spinosum. Most common thing, two things in stratum spinosum. One is desmosome abundance. Second one is Langerhans cells. Revising, keep revising. Birbeck granules, Stannous ricket appearance. Most important marker, that is CD207, CD18. CD207 is also known as Langerine. Very important, guys. Okay, they are macrophages of the skin. Merkel cell, ectodermal in origin. They are producing neurotransmitter and they are responsible for crude touch and sensation. Okay, so they will be working via which pathway? Anti wala pathway. Anti का touch कैसा होता है? That is crude touch. Okay, crude touch will be there. That would be your soft or fine touch. Okay, soft or fine touch. So anterior spinothalamic tract will be included. Look here, guys. This is the image. This is the image we are having. Osteotic eczema. This is the image we are having. Osteotic eczema. And this one is we are having Ichthyosis vulgaris. Here we will be giving what? Because there is no Odlin body, there is no lipid. What we can give? We can give lactocalamine lotion, or we can give some other kind of moisturizer. Here there is problem with the filamentous aggregating protein, that is profilagrin is not converting into filagrin. This is a keratohyalin disorder. Simple, done. Okay, now try to solve this particular question. What is the term used to describe the distinctive findings shown in the image? What is this particular image? What is this particular image is telling us about? Is it a nail pitting? Is it a subungual oil drop sign? Is it a thinning of nails? Is it a pterygium? What is this? What is this particular thing? Very good. This is known as oil drop sign. This is known as oil drop sign. And this is most characteristic lesion you will find in which disease? That is in psoriasis. In psoriasis, the most characteristic lesion, if they ask you, your answer will be this particular thing. If they ask you most common lesion, then your answer will be what? Then your answer will be pitting. Pitting will be most common thing. Okay, pterygium. What will happen in pterygium? You will be having proximal nail fold, which is bifurcating into the nail bed into two parts. Okay, we will be discussing about nail pathology in subsequent slides. Just look at the psoriasis first. Okay, psoriasis, everything that you need to know about psoriasis will be here itself. Okay, we will be discussing complete psoriasis. First of all, what is the most common site of psoriasis? Remember, guys, in the question, psoriasis is basically an autoimmune disorder, and the most common site will be extensor surface of the body. Extensor surface of the body will be psoriasis. Most common type of psoriasis will be psoriasis vulgaris. Vulgaris will be the most common type. Okay, psoriasis vulgaris. What is the mnemonic that you need to remember? P4, polish is the mnemonic. You can remember P4, pitting will be there, bacho. What will be there? Pitting will be there. O4, onycholysis. Onycholysis, I will be telling you the meaning. What is onycholysis? Onycholysis, apart OL will be onycholysis. Apart from that, another O will be there. That is oil drop sign. You can remember. Oil drop sign. I4, it will be irregular. The pitting will be irregular. S4, subungual. H4, hyperkeratosis. So that would be leading to subungual hyperkeratosis. These are the findings that you will be finding. This is known as oil drop sign. This is oil drop sign. This is oil drop sign. This one we can see pitting is there. What kind of pitting? Is it regular pitting or is it a irregular pitting? Remember guys, it is irregular pitting. Irregular. Is it a superficial pitting? Is it a deep pitting? Just remember, superficial मतलब क्या हो गया? Superficial is above. Above superficial, you can remember, you will be finding in alopecia areata. You will be having deep pitting here. Irregular, deep pitting here. Okay. This is your onycholysis. This is your onycholysis. This is your onycholysis. And can you see here, this particular ring is known as Warnhoff ring. This ring is known as Warnhoff ring, and the membrane will be there above it. This membrane is known as Berkeley's membrane. This membrane is known as Berkeley's membrane. So there are some people, naughty people, what they will try to do, they will try to remove this Berkeley's membrane, and what will happen, we will be having this particular sign that is known as pinpoint hemorrhages. When you try to remove that particular membrane, what will happen, you will be having pinpoint hemorrhages. This is known as which sign? This is known as Auspit sign. So what is Auspit sign? Remember guys, Auspit sign will be positive in this particular situation, that is your psoriasis. In your psoriasis, Auspit sign will be positive. Important things done. Okay, now we will be looking for the histopathological slide. Can you appreciate blue color structures? You are appreciating in the stratum corneum, we are having blue color nucleus. So presence of nucleus in the stratum corneum, that is known as parakeratosis. Okay, parakeratosis, presence of nucleus in the stratum corneum. Okay, second thing, can you see hyperkeratosis will be there. There will be abnormal deposition of keratin. Okay, you will be finding, look here, this is the rete ridges. This is what we have seen. This is the rete ridges. Whatever structure is going into dermis, that is known as rete ridges. So what kind of rete ridges you are finding here? Can you appreciate? These are club shaped rete ridges. These are club shaped rete ridges. Club shaped rete ridges will be a feature of this particular thing, that is psoriasis. Apart from that, you will be finding two types of microabscess. What is microabscess? Micro means thoda, that means come. Abscess means collection of pus. Okay, collection of cells, collection of WBCs. So you will be having two types of microabscess. One is this. This is your Kogos pustule, and one more is there, that is known as Munro's microabscess. Munro microabscess. This is known as Munro's microabscess. So these are the two types of abscesses that you will be finding here. Okay, these are the important point that you have to remember. What we have to remember, one is Munro's microabscess, Kogos pustule. Okay, you will be having this type of club shaped rete ridges. You will be having parakeratosis. These four features, if you remember, your life will be easy. Okay, that would be easy. Now try to answer. Now try to differentiate between different type of psoriasis. I have told you the most common site will be extensor surface. Okay, so if there is a psoriasis, along with the psoriasis, what is happening in the psoriasis, there is some kind of pus. Okay, if there is a pus along with the psoriasis will be having scaling. I would be telling you what is scaling. So it will be having scaling. Along with the scaling, you will be having pus. The drug of choice for pustular psoriasis will be acetretin, guys. Acetretin. Can anyone tell me what is the drug of choice for inverse psoriasis? Generally, psoriasis should be on the extensor surface. Here, what is happening? The patient is having inverse psoriasis. Please try to answer the drug of choice for inverse psoriasis. Next, we are having this particular thing. This is known as impetigo herpetiformis. Herpetiformis, again, there will be grouped vesicle. Impetigo herpetiformis, that is the disease you will be finding in pregnancy. Okay, in pregnancy, you will be having psoriasis, and the drug of choice you will be using, we cannot use methotrexate and all those drugs. So we will be using steroids. We can also use cyclosporin. Okay, these are the drugs we can use over here. Can you appreciate this red color structure? That is completely he is looking red, right? So that is erythrodermic psoriasis. Drug of choice will be methotrexate. They will ask you the drug of choice here. Drug of choice will be methotrexate. Okay, scalp psoriasis, you will be having psoriasis in the scalp. The drug of choice that we will be using is steroids. We will be using steroids. Okay, and this guttate, can you appreciate this gutta like structure? What is the drug of choice for this particular thing? Drug of choice for this particular thing is, what is the drug that we are using here? For inverse psoriasis also we are using, guys, methotrexate. We are using methotrexate for inverse psoriasis, but guttate psoriasis is the question. This is the examiner's question, because you will be thinking that maybe I can use methotrexate, maybe I can use steroids, maybe I can use acitretin. You will be stucking with them, but this is generally guttate psoriasis is after a upper respiratory tract infection. So after a upper respiratory tract infection, so what is the drug of choice you will be giving here? You will be using antibiotics, and that is the question that the examiner will be asking you, right? So he will be asking the drug of choice in guttate psoriasis. You will be answering antibiotics. He will be giving you in the option, the patient will be having antibiotics. Okay, so these are the important points about psoriasis. Try to solve this particular question. What is the most probable diagnosis for a 30-year-old woman who has Lacy lesions in her mouth? First thing, Lacy reticular lesions in her mouth and genital area with proximal nail fold that has extended into the nail bed. Okay, this proximal nail fold has extended into the nail bed. Okay, so this is the proximal nail fold which is extending into the nail bed, and this particular sign is known as what? This is a feature you will be finding with pterygium. Guys, this is a feature you will be finding with pterygium. This is a pterygium you will be finding with which disease? Pterygium you will be finding with Lichen planus. Okay, let's discuss the important points about Lichen planus. What are the important points that you need to remember about Lichen planus will be here. You need to look for 5P. What are these 5P? It should be plain top. It should be purple or violaceous can be there. Violaceous or purple will be same thing. Okay, it should be purple. It should be polygonal, pruritic. It will be pruritic and papules. Okay, so they will be plain purple, polygonal, pruritic, papules. If any kind of this kind of appearance you will be finding, that would be your Lichen planus. Look here, this type of lesions will be there. Wickham's tria that has given in the option, that is white reticular lacy pattern. White reticular lacy pattern, if they have given you lacy pattern or cobblestone appearance in the mucosa or cobblestone appearance, अगर इनमें से कुछ भी दिखता है, then your answer will be Lichen planus. This is the most characteristic finding. Pterygium, that is proximal nail fold is extending into the nail bed. Okay, nail bed. This is your lateral nail fold. This is your proximal nail fold. It is extending into the nail bed, dividing the nail into two parts. That is a distinctive feature. Okay, apart from that, what are the histopathological thing that you have to remember? Here the patient will be having two things you have to remember about the rete ridges first. Okay, so rete ridges will be, what shape of rete ridges you will be finding? You will be finding this type of rete ridges. These are known as sawtooth rete ridges. These are known as sawtooth rete ridges. These are known as sawtooth rete ridges. Apart from that, remember two more things will be there. First is Max Joseph cleft. If you don't understand, just remember. And second one is your C-weight bodies. These are the important thing. Hypergranulosis will be here itself. Okay, same things will happen, right? So this is about the histopathological examination of this particular thing. Okay, now try to identify and try to solve these questions. Okay, a 26-year-old male presented with erythematous plaque covered with silvery scales. Whenever you will be finding in the option silvery scales over the extensor surface of both the arms. Extensor surface, most common presentation. Okay, punctate pitting. What kind of pitting? Irregular deep pitting. Deep pitting was noted on the examining the nails. What is the most likely diagnosis? Your answer will definitely be psoriasis. If they want to ask about Lichen planus, they will be giving pterygium. Okay, they will be giving different history, right? Very good. Patel, Sindhu, Tanya, Megha, right? Try to solve this one. A 45-year-old male patient is presented to dermatological clinic with itchy skin rash. The patient is having itchy skin rash. Physical examination revealed flat-topped, polygonal, purple papule with fine white line on the surface. The lesions are primarily located in the inner wrist. Remember, guys, they are present on the flexural surface. Okay, and forearms. Okay, as well as on the lower back. The patient reports that he has been experiencing oral discomfort. Okay, there are some lacy patches inside the cheeks. There is no family history of similar condition. What is the most likely diagnosis over here? My dear doctors, please try to answer. Very good, very good. I'm getting good response. So they are talking about lichen planus. They are talking about lichen planus. Lichen planus. All the symptoms are here. That is given of lichen planus. Okay, so that is lichen planus. Now try to solve this one. Auspit sign is seen in. Auspit sign is seen in which disease? Auspit sign is seen in which disease? Is it seen in pemphigus? Is it seen in psoriasis? Auspit sign. What is Auspit sign? Again, right now we have seen we are having bond of ring. We are having Berkeley's membrane. When we are removing the Berkeley's membrane, what will happen? You will be having pinpoint bleeding. That is known as Auspit sign. So Auspit sign will be presented in psoriasis vulgaris. Pustular psoriasis will be having lots of pus. You are not able to see the sign, right? Pemphigus and bullous pemphigoid we will be discussing in the subsequent slide. Okay. Next one. An elderly male patient presented with meningitis. The patient is having symptoms of meningitis. The CSF sample was subjected to gram staining. Gram staining has been done. The microscopy was shown in the image below. Which of the following will be characteristic of this likely organism? What can be the organism, guys? First of all, when you look at the gram staining, try to identify the color. Okay, so if it is a violet color, what can be the causative organism? Is it a gram positive bacteria or is it a gram negative bacteria? Violet will be gram positive, pink will be gram negative. So first thing they have given is a violet color bacteria. Can you see? Right, so this is a violet color bacteria, so it is a gram positive bacteria. First thing. Second thing, are they appearing in the form of a cocci? What is cocci? Cocci is a round structure. What is a bacilli? Bacilli is a this type of structure. Okay, so are they cocci or bacilli? They are definitely not cocci, so cocci will be ruled out. If you want to solve question based on the image, you can solve like that. Okay, just giving you the hint. Okay, second thing, they are giving you symptoms of meningitis. They are giving us the CSF sample. Lumbar puncture we are doing lumbar puncture in this symptoms. If the patient is having symptoms of meningitis, what are the symptoms? Patient is having nausea, projectile vomiting, patient will be Kernick positive, patient will be Brudzinski positive, patient will be having neck rigidity. So these are the symptoms of meningitis. Okay, you can identify. So there are elderly patient. Look here, elderly patient, male patient. Two possibilities can be there in meningitis. One is, for example, let me write it for you. Elderly patient can be having two possibilities. It can be Streptococcus agalacti. Either it can be Streptococcus agalacti. Second thing, it can be Listeria. First thing, you can directly rule out Streptococcus agalacti is the most common cause of. Streptococcus. Remember, if you know the morphology, if you have studied microbiology, you will be answering that clearly. They will be present in the Streptococcus will be present in the chains. They will be having chains. Okay, can you appreciate any chains? No, we cannot appreciate any chains. So this cannot be Streptococcus agalacti. Whereas agalacti is the most common cause of neonatal meningitis. If they ask you, the answer will be Streptococcus agalacti. Here, this is a gram positive bacilli. Is it a cocci? No, is it not? It's not a cocci. It is a bacilli. It is a gram positive bacilli. You can definitely answer. This is Listeria. Remember, guys, Listeria, we will be using which agar? Palcum agar. Listeria, Lisa auntie, I have told you, Palcum agar. We will be having Anton test, and this one will be present in your cold environment. Okay, 4 degree. Okay, 4 degree. Okay, so those female who are eating from fridge, pregnant female eating from fridge, that is the common history you will be getting. Okay, so it will be having a motility, and this is the neat PG question from last exam. It will be having a motility that is known as differential motility. What is that? Differential motility का मतलब क्या होता है? The meaning will be, there will be two types of motility. Remember, guys, when we are young, we are drinking outside, we are roaming outside, right? So those people who are young at the age of 22, what they will be doing? they will be drinking and roaming here and there. But after some time, what happens, after a age, they will stop drinking and they will stop going outside. Even if they are drinking at their home. Just for the examples sake, you can remember that they will be motile at 22 degrees Celsius, and they will be non-motile at 37 degrees Celsius. This is how you can remember this particular thing. Yes, we are coming to the motility part also. Okay, so this is the thing you have to remember. Is it done, guys? Is it done? कर लोगे ऐसा क्वेश्चन? So we are having these motilities. First one is about the tumbling motility. Tumbling का मतलब क्या होता है? Tumble कौन करता है? Who will be tumbling, right? The person who is drinking. What drinking? You can remember Listerine. Listerine is just like alcohol. You can remember Listerine. Listeria will be causing tumbling. Second one is your darting motility. Vibrio cholera will be having darting. VCD, you can remember earlier we used to have VCD, that is Vibrio cholera and Campylobacter jejuni will be having darting motility. Just like the dart game we are playing, that would be your darting motility. Swarming, we will be seeing swarming with the proteus. Swarming का मतलब क्या होता है in हिंदी? छा जाना. Swarming मतलब ये completely छा जाएगा. Okay, that is your swarming motility. Falling leaf, गिरा दिया, you can remember giardia. You can also remember Giradia. Giardia is like Giradia. Okay, so you can remember Giardia is like Giradia. Next one is your corkscrew motility. Corkscrew motility बच्चों कहाँ देखने को मिलेगा? You will be seeing this corkscrew motility in Treponema pallidum. Yes, just now we have seen Treponema pallidum will be causing what? Just a moment, guys. So falling leaf-like motility we will be seeing in the cases of Giardia. In the cases of Giardia, we will be seeing this falling leaf-like motility. Corkscrew motility we will be seeing in the cases of Treponema pallidum. We will be seeing in the cases of Treponema pallidum. Treponema pallidum will be causing what? Okay. Giardia trophozoite will be having 4 pairs of flagella. You will be having questions from this also. Okay. Lashing motility. Lash को कैसे रखेंगे? We can lash को कैसे रखते हैं? We can do बोरे में लपेट के. Okay, we can remember like that. So लाश को कैसे रखेंगे? बोरे में लपेट के. These are basically spirochetes. So lashing motility we will be seeing with the spirochetes. Okay. Twitching motility, T for twitching, T for Trichomonas vaginalis. Twitching is seen with Trichomonas vaginalis. It will be having 5 flagella. Okay, it will be having 5 flagella. Trichomonas vaginalis is this. Okay, this is your Trichomonas vaginalis. That would be causing what we have seen. That is your Pulpitis macularis. Pulpitis macularis, basically also known as strawberry vagina. Okay. Rotatory motility we will be seeing with Ballantidium. Ballan से क्या करते हैं? रोटी बनाते हैं. You can remember like that. Okay. Ballan से रोटी बनाएंगे. So that is your Ballantidium choline will be having rotatory motility. Slow form of swarming, that is known as Clostridium. That is seen with Clostridium motility. And differential motility. Remember guys, differential motility is seen with Listeria, and that is the question they have asked you. Okay, that is the question they have asked you. Then guys, tumbling, Listeria, darting, VCD, swarming, Proteus, falling leaf like Giardia, corkscrew will be Treponema, lashing will be Borrelia leptospira, twitching will be Trichomonas, rotatory will be Ballantidium, stately will be Clostridium, and differential motility will be seen with this particular thing. Okay. Now try to solve this particular question. Again, there is a voice error. Volume full है. आज ही हो रहा है. I don't know what is. Is that fine? Is that fine now? Am I audible now? Am I audible? Just give me a moment, guys. Audible but not clear. What is coming? Echo is coming or something else? Echo is coming or something else is there? Do let me know. We can clear it. Is it fine now? Is it fine? Do let me know if it is fine. No, it's fine. Okay. Okay. Okay, guys, we can continue now. So the question is, a patient presented with the complaints of fever for last 3 days. Patient is having fever from last 3 days. There is general fatigue. Echocardiography revealed vegetation on the valves. Remember, guys, whenever we will discuss in the terms of valves, जब भी valves की बात करेंगे, we are talking about some kind of endocarditis. Endocardium is what? Endocardium is nothing but your valves, right? Your heart valves. Okay, you are having blood culture. Blood culture was done. The organism in the culture shows what kind of hemolysis. Very very important hint, that would be showing you alpha hemolysis on the blood agar, and was resistant to optocin and bile. It was resistant to optocin and bile. Which of the following is most likely implicated in this condition? First of all, try to identify. First of all, try to identify. We are having mycoplasma. Mycoplasma, what is the stain that we have, what is the culture media that we have seen? We are having papillomedia, we are having ppl, or we are having ketone media. Okay, we are having ketone media. And remember, streptococcus viridans will be causing what? Subacute bacterial endocarditis. Subacute bacterial endocarditis. Let's see how streptococcus is getting divided. Okay, on the basis of what we are having division of the streptococcus, we will be discussing, right? So streptococcus will be present in the form of chains. These are the chains, these are the looking of the streptococcus, and they are divided on the basis of hemolysis. We are having, guys, beta hemolysis. Beta means complete hemolysis. Beta hemolysis is complete hemolysis, you can appreciate. Alpha hemolysis is partial hemolysis. Alpha will be partial hemolysis. And this one is your gamma hemolysis. There will be no hemolysis. There will be no hemolysis. There will be no hemolysis. That means gamma, those bacteria are categorized in the gamma, which are not doing hemolysis. Okay, so we are having this type of classification. Let's see. Alpha will be doing what? Alpha will be doing what? Alpha will be partial hemolysis. Alpha will be partial hemolysis. Two things can be happening here. First thing, we are doing a test, that is optocin test. What is optocin? Optocin is what? Optocin is an antibiotic. If we are giving optocin and the bacteria is dead, that means it is a streptococcus pneumonia. Streptococcus pneumonia, also known as pneumococcus, medically important bacteria. Questions are being asked from this. Okay, it is a lens shaped bacteria. It is a diplococci. It will be found in the double bacteria. Okay, you will be finding two bacteria together. Okay, it is a diplococci. They will be having on chocolate agar, they will be having draughtman like colony. They will be having draughtman like colony, or they will be having carom coin appearance. They will be having carom coin appearance. Okay, just a moment, guys. Sorry for the interruption, guys. Okay, so we are having optocin sensitive. First of all, we will be looking at alpha hemolysis. Alpha hemolysis will be optocin sensitive. Optocin sensitive will be streptococcus pneumonia. अगर ये मर जाता है, that is Streptococcus pneumonia. Now, Streptococcus pneumonia is also known as pneumococcus. The shape will be lens shaped, okay, and it will be diplococci. Important thing, on chocolate agar, it will be giving a specific appearance. This is known as Trotman like colony or carom coin appearance. Okay, we are already studying a reaction. We are also having a reaction that is known as Q-lung reaction. It is a capsulated bacteria, so it will be having Q-lung reaction. One more reaction we will be studying about Bacillus anthracis. What is that reaction known as? Try to answer. Okay, try to answer what is that reaction known as. That we will be seeing with the Bacillus anthracis. Okay, this one will be the most common cause of two things. One is typical pneumonia. What is typical pneumonia? That is basically lobar pneumonia. We are having typical atypical pneumonia. Okay, so that is the most common cause of typical pneumonia. Okay, second thing, it will be the most common cause of meningitis overall. Meningitis, the most common cause overall will be Streptococcus pneumonia or pneumococcus. Streptococcus pneumonia or pneumococcus. These are the important points you should be knowing. Optochin negative will be Streptococcus viridans, and remember, viridans will be causing subacute bacterial endocarditis. It will be causing what? Subacute bacterial endocarditis. And remember, Streptococcus mutans. Remember, mutants मुंह में क्या करेगा? Mutants will be causing dental caries. Okay. So that is about the alpha hemolytic streptococci. Now we will be discussing about the beta hemolytic streptococci. That is what we are calling group A beta hemolytic streptococci, group B beta hemolytic streptococci. Okay, so basically just remember simple word. Beta are B positive, they are B positive, and they are PR positive. They are B positive, they are PR positive. Okay, they are B positive and they are PR positive. They will be negative for CAMP test and they will be negative for HHT reaction. But just remember this particular thing what I am telling you. Okay, so we are having group A beta hemolytic streptococci. The example will be Streptococcus pyogenes. Pyogenes will be having two types of reactions, two types of complications. One is suppurative complication, another one is non-suppurative complication. Suppurative complication, first one is impetigo. Impetigo, is it a bullous type of impetigo or it is a non-bullous type of impetigo? The question, bullous type of impetigo you will be finding with Staph aureus. Staph aureus. Bullous means there will be a blister kind of thing. Okay, there will be a blister kind of thing. Here you will be having this type of thing. This is known as honey colored crusting. This is known as honey colored crusting. Very, very important. Honey colored crusting is a feature of this particular thing. Okay, second is about the quinsy. Quinsy is basically paratonsillar abscess. This is paratonsillar abscess. One more differential is there, that is Quincke's disease. That is a different thing. What is Quincke's disease? बुल्ला का मतलब क्या होता है ना, we will be discussing now, you will be understanding everything. Okay, scarlet fever, it can cause scarlet fever. Non-suppurative complications can be acute rheumatic fever that we will be studying in different subjects, and then we are having acute glomerular nephritis. You will be checking for the levels of titers of anti-streptolysin O antibodies, all those things that would be causing. Okay, so this is the causative agent for them. Okay, group B streptococci, important thing, group B will be B negative, PYR negative. They will be positive for CAMP. CAMP is basically Christie Atkins Monk Peterson. Christie Atkin Monk Peterson, they are the name of the scientist, and HHT positive. Okay, so this is your CAMP test. We are you will be finding this type of zone of inhibition over here. This type of zone of inhibition over here. Look here. This type of, they will be binding together. Here is the Staph aureus, here is the group B streptococci. Okay, so that is CAMP positive and most common cause of neonatal meningitis. Second most common cause, if they ask you, your answer will be second most common cause of neonatal meningitis, your answer will be E. coli. Okay, third, if they ask you, that would be Klebsiella. Lastly, we are having gamma. Gamma, we need to remember certain points. Gamma, we need to remember certain points. Gamma will be having spectacle shape, first thing. Second thing will be 6.5% sodium chloride में भी grow कर जाएगा, bile में भी grow कर जाएगा, and they will be causing endocarditis in which patient which are having a history of IV drug abuser. IV drug abuser. Okay, it will be having a resistance also vancomycin to vancomycin. That is why it is known as vancomycin resistant enterococci, and that is due to a gene known as VAN gene. That is due to a gene known as VAN gene, VAN gene. Okay, we are having this thing. Okay, so These are the important points that you should be remembering about the Streptococcus. Here answer will be Streptococcus viridans, because it is a alpha hemolytic bacteria, optochin resistant. Okay, alpha hemolytic optochin resistant, that would be causing endocarditis, subacute bacterial endocarditis. Your answer will be SABE, right? Try to answer this. A patient has complaints of fever with mild headache associated with some difficulty in swallowing. Patient is having difficulty in swallowing. Throat examination reveals swollen glands are there. A thick whitish membrane is over there over the tonsil, which bleeds on scraping. A sample is taken from the excudate and the gram staining is done, which is shown below is the causative organism that is associated here, right? Try to answer. Is it a molluscum contagiosum? What you will see in the molluscum contagiosum, guys? Pearly white umbilicated nodules, dome-shaped nodule. Okay, pearly white umbilicated nodule. That is a feature of molluscum contagiosum. Bacillus anthracis. We will be discussing about Bacillus anthracis. This is your Corynebacterium diphtheria. First thing you will be finding, it is a gram-positive bacteria, gram-negative. It is a gram-positive bacteria. Second thing, you can appreciate what kind of appearance you are finding here. You are finding this Chinese letter appearance. Chinese letter appearance. And the most important thing that you need to remember for further questions, these are the granules that you are seeing. These are known as, what are the different names of these granules? These are known as metachromatic granules. These are known as metachromatic granules. These are also known as polymetaphosphate, Babes-Ernst granules, okay, and volutin granules. Polymetaphosphate, Babes-Ernst granule, or volutin granules. These are the name you have to remember. Okay, so these are the things you have to remember about Corynebacterium diphtheria. What are the stains that we can use? We can use four types of stain we can use. That is plain. Okay, P4 we can use Ponders. L4 we can use Loeffler's, that is the best one, Loeffler's. A4 we can use Albert stain, and N4 we can use Neisser stain. Can anyone tell me, is it a bacteremia or is it a toxemia? Diphtheria is a bacteremia or a toxemia? You will be finding this pseudo membrane, guys. When you try to peel off that pseudo membrane, what will happen? There will be some bleeding. Most common site of this pseudo membrane will be fascial pillars. Most common site will be fascial pillars. Apart from that, the patient will be having a history of bull neck also. In some cases, you will be finding history of bull neck. Okay, bull neck history will be there. Is it a toxemia? Med Arisha, very good, Meher. So yes, it is a toxemia. Okay, so whenever you are having toxemia, you will be giving what? Anti-diphtheric serum. And what is the dose that you can give? You can give up to 80,000 to 1,20,000 unit. Okay, so that is the dose you will be giving, 1,20,000 from 80,000. Okay, it is a toxemia. Okay, what is this? This is your Corynebacterium minutissimum. Very important question from Derma. This is your Corynebacterium minutissimum. What it will be causing? Remember, guys, it will be having an enzyme. What is that enzyme? This enzyme will be doing what? It will be releasing a keratolytic substance. Okay, so this one will be having a keratolytic enzyme. Keratolytic enzyme is there, and whenever a keratolytic enzyme is there, it will be breaking the keratin. What will happen when it will be breaking the keratin? When you are looking under wood lamp, this is your wood lamp examination, you will be finding this type of fluorescence. This is known as which fluorescence? This type of fluorescence is known as, yes, try to answer. What is this? This is coral red fluorescence. Coral red fluorescence. This is coral red fluorescence that you will be finding in this particular case. And this disease is known as Corynebacterium minutissimum, will be causing what? Erythrasma. Okay, erythrasma. It will be causing erythrasma, and this will be the thing that you will be finding over here. Okay, what is the complication? One more thing, one more question that has been asked long back. They have asked you, what is the complication of diphtheria? That would be myocarditis. The complication of diphtheria would be myocarditis. Okay, the complication will be myocarditis. Okay, next, try to identify a 25-year-old patient, with skin abnormalities. On examination, you know the patient is having erythematous papules with the central depression filled with some kind of a pus. They are approximately 0.5 centimeter in diameter, surrounded by red and halo. What is the best describing this primary skin lesion? First of all, let me teach you what are these lesions, then you will be answering. Okay, then you will be answering these lesions. Okay, first of all, let me teach you what are these lesions. Okay, so first of all, try to understand what is a primary lesion, what is a secondary lesion. Primary lesion क्या होता है? Primary lesions are due to primary disease. Okay, primary lesions are due to primary disease, and when these primary lesions are not getting adequate treatment or because of trauma, because of scratching, what will happen? Because of inadequate treatment, what will happen? These primary lesions will be converting into secondary lesions. Okay, these primary lesions will be converting into secondary lesions. So what are the primary lesions that you should be knowing? First one is the flat lesion. If there is any kind of flat lesion or there is any kind of color change, if size is less than 1 centimeter, we call it macule. What do we call it? We call it macule. If the size is more than 1 centimeter, we call it patch. We call it a patch. Okay, if there is a clear fluid filled lesion, look here, if there is a clear fluid filled lesion less than 1 centimeter, we call it vesicle. So that is why we are calling in herpes you will be having multiple grouped vesicle. They will be having clear fluid filled lesion less than 1 centimeter. If these lesions are big, you will be calling them bulla. अगर वही लीजन बड़े हो जाएंगे तो क्या हो जाएगा? बुल्ला हो जाएगा. लाइक वी आर स्टडीइंग इन बुल्लस पैम्फिगोइड. व्हाट इज बुल्लस पैम्फिगोइड? क्लियर फ्लूइड फिल्ड लीजन मोर देन 1 centimeter is bulla, right? Next thing, we are having solid lesions. We are having raised or circumscribed lesions. Let's look at this. We are having papule. If it is a solid lesion, we are having papule less than 1 centimeter. If it is more than 1 centimeter, just a moment. If it is more than 1 centimeter, we call it plaque. If it is more than 1 centimeter, we call it plaque. And if it is going into the depth, like we are having nodulocystic acne, right? So nodulocystic acne is, if it is going into depth more than 1 centimeter, we call it a nodule. We call it a nodule. Okay, any lesion with pus fill. If there is a pus filled lesion, try to remember pus filled lesion, small, we call it pustule. If it is small, we call it pustule. If it is a big lesion, what do we call it? We call it abscess. We call it abscess. Any pus filled lesion, small pustule, big one will be abscess. These are all primary lesions. Okay, wheals are characteristic feature of which disease? Try to answer. You will be finding wheals in urticaria. What is a wheal? Here is the wheal. This is a wheal, right? Itchy lesion, erythematous will be there, and edema will be there. For example, machhar ne kaat liya. What will happen? You will be having some kind of itchy lesion that would be having some kind of erythema, that would be having some kind of edema. So that would be a wheal. What is petechiae? Petechiae, you will be having less than 2 centimeter. We call it petechiae. Purpura 2 से 5, 2 to 5 will be purpura. More than 5 will be ecchymosis. Okay, and what is a cyst? Cyst is a cyst will be having some kind of collection of cells or fluid that would be covered by a epithelial cell is known as cyst. I would be showing you all the images. First, let's see the secondary lesions. What the secondary lesions we are having? First one is your scaling. What is the scale that we will be discussing? We will be discussing multiple scale. Basically, I have told you desquamation of the stratum corneum. Stratum corneum bahar nikal ke chipak gayi. That is your desquamation of the stratum corneum is known as scaling. Crusting, we have seen a honey colored crusting. What is that? Nothing but dried up exudate. So crusting is a type of secondary lesion. Crusting is a type of secondary lesion you are finding with Streptococcus. Okay, erosion. What is the erosion? There will be loss of epidermis. If there is loss of epidermis, we call it erosion. When this loss of epidermis will be a linear thing, we call it excoriation. Linear erosion is known as excoriation. What is lichenification? What will happen in the lichenification? Three things you have to remember. It can be itchy, it will be having some kind of color change, and it will be having thickening. It will be having thickening. And what is the scar? Scar is a permanent fibrotic change. Okay. What is a scar? Scar is a permanent fibrotic change. One more you need to remember. What is the ulcer? Ulcer will be loss of epidermis plus dermis. If there is loss of epidermis, we call it erosion. If loss of epidermis plus dermis, we call it a ulcer. Simple things are there. Ulcer is a secondary lesion. Okay. Now see, this is a lesion which is more than 1 centimeter. It is having clear viscous clear fluid is there, that is known as bulla. Macule क्या होगा? Macule will be flat discoloration. If it is a solid lesion which is going deep, we call it nodule. If it is a circumscribed flat lesion more than 1 centimeter, we call it patch. Papule will be a solid lesion less than 0.5 or 1 centimeter. Okay, plaque will be more than 1 centimeter. These are your pustules. Pus-filled lesions are known as pustules, and this is a vesicle. You will be having clear fluid. Okay, this is a wheal you are identifying. Okay, and this is your scaling. Scaling is a feature you will be finding in psoriasis, silver white scale. This is your crust. Crust is dried up exudate. Okay, what is a fissure? There is a crack or split will be there. These are your excoriation. Basically, what is excoriation? Loss of epidermis. Only linear loss of epidermis is known as excoriation. What is erosion? There will be loss of epidermis. Okay, and what is lichenification? There will be color change, there will be itching, and there will be hypertrophy will be there. Okay, thickening will be there. And scar is a permanent fibrotic change. Are you guys done with these lesions? समझ में आया? All these lesions are clear to you? Okay, now try to solve this question. So what the examiner wants to know, the lesion will be having erythematous, papules, all those things are there. Ultimately, what you need to look, pus less than 0.5 centimeter. What do we call it? Pus is there less than 0.5 centimeter. What do we call it? It is a pustule. Bulla, if it is having clear fluid more than 1 centimeter, wheal will be having edema, erythema, there will be some itchiness will be there. Fissure will be linear crack. So your answer will be pustule over here. Now try to answer this question. A 50-year-old patient present to the dermatology clinic, okay, with the concern about a skin condition. Upon examination, you are noticing multiple irregularly shaped crusted erosions on the patient's arms and leg. These skin lesions appears to result from scratching. Scratching means what? It is a trauma. It is a secondary trauma that they are talking about. And secondary lesions, out of them, if you just want to rule out, all out of them, the secondary lesion will be excoriation. And we already know excoriation is what? It is basically a linear erosion. It is a linear erosion that you can easily identify. There will be loss of epidermis along a line. That is your linear erosion. Okay, so your answer will be D in this particular case. Okay, wheals will be itchy if they have given you itchy lesions. Vesicles will be what? Vesicles will be having clear fluid filled lesion. You have to see it again. Then only you will be able to recall. Okay, what is a papule? Papule will be, what is a papule? Papule will be solid lesion less than 0.5 centimeter. That is your papule. Okay, done guys. Now try to answer this one. These are the important questions. Nowadays they are asking this type of question in your examination. A 25-year-old male patient presented with linear arrangement of hypopigmented patches on her trunk following the pattern that resembles the letter V. Okay, the lesions are asymptomatic and have been present since childhood. What is the most likely diagnosis? Try to answer. What is the most likely diagnosis in this particular case? What is the most likely diagnosis? So basically, what kind of line are they? Are they Langer's line? Are they Blaschko's line? Or is it a linear psoriasis or scleroderma or something like that? Okay, so to understand this, basically what you need to see, you need to look at the head part first. If you are finding these circular lines, let me give you how to solve the question. So if you are finding these circular lines, straight away go for the answer, that is Blaschko's line. Look here, these are basically, what are they? They are basically embryonal They will be telling us embryonal migration of keratinocyte. They will be telling us about the embryonal migration of keratinocytes. Three examples we are having that has been asked in your examination. First one is your incontinentia pigmenti. Continentia pigmenti. Second is your epidermal nevi. And third one is your hypomelanosis of Ito. These are the three examples you have to remember, and they are the embryonal migration of keratinocyte. They are the Blaschko's line. Sir, what is Langer's lines? Look here, these are the Langer's lines. Langer's lines. One more thing you will be studying about dermatome, I will be telling you here itself. So basically, what are Langer's lines? Read the question first. A 30-year-old patient underwent surgery for a skin lesion on the abdomen. Okay, he is having some kind of surgery. The incision was made perpendicular to the line of tension. These are also known as lines of tension. So whenever you will be going to your OT, you will be finding these charts. You will be having these charts, and these charts will be having Langer's lines. Okay, they will be telling us where to cut. Okay, because that would be leading to a good wound healing. Okay, the wound edges have a tendency to gap and heal poorly. Okay, which concept of skin anatomy would explain this phenomena? So how we can explain this? Basically, these Langer's lines, they are parallel to the collagen. These lines are parallel to collagen fibers and perpendicular to muscle fibers. Okay, during the incision in surgery, during incision, we are using these lines, using this for better healing. These are your Langer's lines. These are also known as lines of tension. These are also known as lines of tension. These are your Langer's lines. Okay, so now you can differentiate. Here there is nothing like circular. If these type of lines you will be finding, that is your Blaschko's line, and the other one will be Langer's lines. One more line you will be finding, that is dermatome. That is basically dermatomes, and there will be some infections which are running along the dermatome. Like example, I have given you herpes zoster. Herpes means you already know, that is grouped vesicle, and zoster means along a nerve segment. Zoster, the meaning will be along a nerve segment. For example, we are having thoracic nerve segment. Okay, so the patient will be having grouped vesicle around a nerve segment, that is known as herpes zoster. Can anyone tell me how much is the drug that we are giving, acyclovir? How much acyclovir we are giving in the patients of herpes zoster? How much is the drug that we are giving in the patients of herpes zoster? Again, next one is your, try to solve this particular question. Which pathogen causes the attachment and effacement type of lesion in the intestinal mucosa? Which of the following lesion will be causing attachment and effacement type of lesion in the intestinal mucosa? First of all, we are talking about, look at the, very good Meher, that is 800 mg. There's no problem. There are some things in life where we cannot do anything about that. Don't worry. That is the best we can do. Okay, so we are having ETAC. We are having E. coli. Basically, we are having what? Basically, we are having everything related to E. coli over here, right? Everything related to E. coli we are discussing. So what are the different things we have to see about E. coli? What is the most common cause this E. coli will be causing? Most common cause of UTI. What is the most common cause of UTI? Your answer will be E. coli. If I ask you what is the most common gram-positive bacteria causing UTI, then your answer will be what? Try to answer. Diarrhea. Okay, we are having scromboid. It can cause scromboid fish poisoning. That was a question they have asked you. We are having Fourner's gangrene. Fourner's gangrene, you know, when the patient is coming to the OPD, Fonus gangrene, everyone will be understanding that the patient has already came, right? It will be a very foul smelling thing, right? So it will be causing UTI, it will be causing diarrhea, it will be causing scromboid fish poisoning, it will be causing foreigners gangrene, okay? What are the important things out of them we need to discuss? There are certain things, there are certain types of E. coli that we need to know, and the mnemonic is Pitha, Pitha. So what would be your answer? What would be your answer from here? We will be discussing these things further after the class. We can discuss. Okay, so we are having enteropathogenic E. coli, enteropathogenic. We are having enteroinvasive, I for invasive, T for enterotoxigenic E. coli, toxigenic, H for enterohemorrhagic E. coli, enterohemorrhagic E. coli, and A for we are having enteroaggregative E. coli. Aggregative. Okay, what are the different diseases that are caused by these particular types of E. coli? Okay, what are the different diseases? I am asking A and E lesions will be seen with attachment and effacement type of lesion in the submucosa are seen with which type of E. coli? Okay, try to answer. Enteropathogenic, just remember P for pathogenic, it will be causing diarrhea in the pediatric age group patient, pediatric patient. Invasive means it will be going into the blood. That would be resembling what? Shigellosis. It will be resembling shigellosis. Invasive will be resembling shigellosis. Okay, shigellosis. Toxigenic, T for toxigenic, T for travelers diarrhea. Those people who are coming from abroad, they are having some kind of diarrhea, that is travelers diarrhea because of E. coli most likely. We are already immune. We are eating burger, samosa, dosa, whatever we are eating, we are already immune, right? Next one is your enterohemorrhagic. That would be causing hemorrhagic colitis. That would be causing hemorrhagic colitis. And enteroaggregative will be causing what kind of diarrhea? That is persistent type of diarrhea. Persistent type of diarrhea. Persistent type of diarrhea. Okay, so where do you find attachment and effacement type of lesion? You will be finding in this pediatric age group. You will be having this attachment and effacement type of lesions, right? So your answer will be enteropathogenic. Where is the pathogenic? That is the answer. Enteropathogenic E. coli will be the answer from this particular slide. Okay. Okay, how do you culture? How do you culture? What is the culture media? The culture media we are using is clad. We are using clad, 16 lactose electrolyte deficient media, that is the clad media. And what is the sample that you will be taking? You will be taking, guys, remember, you will be taking midstream urine. You will be taking midstream urine. Which one is better, clad or McConkey? Which one is better, McConkey or clad? Try to answer. Okay, next one, along with this, it is connected one. Try to answer. Hemolytic uremic syndrome is associated with. Hemolytic uremic syndrome is associated with what? Hemolytic uremic syndrome is associated with E. coli. Okay, E. coli 0157 H7 will be there. Okay, H7157. So that is the hemolytic uremic syndrome that is having association. Yes, that is HUS, right? HUS. Why? Okay, next try to solve this question. A 40-year-old man presented to OPD with high fever. The patient is having high fever, constipation for last 3 weeks. Past 3 weeks. He has already had some drugs and he is having which kind of diarrhea? Pea soup diarrhea. Pea soup diarrhea. Very, very important thing. Okay. Examination. He is also having relative bradycardia. Another important thing. Okay. Hepatosplenomegaly is also given. Okay. Your answer will be, first of all, apart from answer, try to give the diagnosis. What is the diagnosis over here? What is your diagnosis? I am talking about what? Which disease, guys? I am talking about which disease? I am talking about typhoid. I am talking about typhoid. Typhoid is due to Salmonella typhi. What is the root? What is the root? If I ask you, you will be finding history of feco-oral root. Feco-oral root. Okay, it can be feco-oral root. Feco-oral root. And what are the peculiar features that the question can give you? You will be having a specific type of fever. What is that? That is step ladder pattern of fever. You will be finding, bacho, you will be finding step ladder pattern of fever. That means today he is having fever, next day he will be having more fever, next day he will be having more fever. Okay, just like that. That is step ladder pattern of fever. Apart from that, the patient will be having rose spots. Patient will be having rose spots. Okay, the patient will be having rose spots on the body. Apart from that, the patient will be having a diarrhea that is known as what kind of diarrhea? Pea soup diarrhea. Piece of diarrhea. And the most important sign that is already given, that is relative bradycardia. This particular thing is known as Faggot sign. This particular thing is known as Faggot sign. Okay, we are looking for two types of antigen over here. One is O antigen, another one is H antigen. O antigen will be a somatic antigen. It is a somatic antigen that is present on the outer capsule, right? And H antigen, remember, it is present on flagella. Remember, like flagella will be looking like that, double L. So it will be having, flagella will be having which antigen? H antigen. K antigen will be present in your capsule. Okay, K antigen will be present in your capsule. O antigen you will be finding lipopolysaccharide. Okay, that would be in the gram negative you will be finding. Okay, so we are checking for O and H antigen. We will be checking the titers of these antigens. Okay, what is the enrichment media? What is the enrichment media? We have already discussed in the question. What is the enrichment media for Shigella and Salmonella? That is, as for Shigella, as for Salmonella, your answer will be selenite F broth, bachcho. Selenite F broth. Okay. And what is the selective media? Selective media means selective में एक की growth होगी. Okay, selective media. You know what happens? Shigella and Salmonella, both of them are sisters. Okay, Shigella and Salmonella, both of them are sisters. But इसने क्या किया? साल्मोनेला ने क्या किया? ये विल्सन के साथ में भाग गई. शी हैज रन अवे विद द विल्सन एंड ब्लेयर, एंड ये भाग गई तो क्या हो गया? मुंह काला हो गया. दैट वुड बी गिविंग यू जेट ब्लैक कॉलोनीज. जेट ब्लैक colonies, that would be giving you jet black colonies. That is how you can remember. And what is the transport media? What is transport media? Transport media is the media where there will be no growth. We will be utilizing it for transportation purpose. Okay, so that is the transport media. And what is the transport media? Sex media. So Shigella, Salmonella ने धोखा दे दिया. What Salmonella has done? Salmonella has done what? Salmonella will be having this type of selective media, that is Wilson. She ran away with Wilson, and she has done jet black colonies. She will be having jet black colonies. Okay, and the test we will be having is, remember guys, it is the test that we will be doing. What the examiner wants to know, the best test. Basu, you remember Basu, right? So what is the Basu? Your answer will be what? Here you will be having which kind of test? You will be having which kind of test here? You will be having antigen testing, that is Vidal test. Okay, second week is ending, right? So that is Vidal test. Vidal test will be there. Okay, try to solve this one. Try to solve this one. A patient presented with the abdominal pain. Patient is having diarrhea. Step ladder pattern of fever. They are repeating the same question. His also complaints of headache, malaise will be there. His symptoms are gradually worsened over the past 2 weeks. Which of the following is the best diagnostic test? Okay, so again your answer will be Vidal test. Remember guys, it is not culture. Those people who are having mistake, it is not culture, it is urine ELISA that we are doing. Urine ELISA that we are doing. Okay, earlier it was ELISA. Yes, so urine ELISA we are doing, we are not doing culture. Okay, try to solve this particular question. A 45-year-old male presented with multiple sexual partner, okay, with the palmoplantar rash. What is the problem he is bringing? He is having some kind of rashes on the palms and the plantar areas. So that is palmoplantar rash. On examination, you are finding mucocutaneous papules on the scrotum and lymphadenopathies observed. Which of the following is the likely to be the diagnosis? What is the diagnosis? Remember guys, psoriasis, this is the extensor surface or inverse surface? This is inverse surface. Psoriasis is a feature of extensor surface. Generally, apart from inverse psoriasis, what we have seen, extensor surface, apart from that, there should be given some silver white scaling. Okay, there is nothing like that. So it is from primary, secondary or tertiary syphilis. Primary syphilis, what are the things you will be finding? Primary syphilis will be having chancre. Primary syphilis will be having chancre. Secondary syphilis will be having these things, and these things are known as condyloma, condyloma lata. These are known as condyloma lata. These are known as condyloma lata. Apart from that, from dermatology, we are doing integration. So we are having a type of alopecia that is known as moth-eaten alopecia. Moth-eaten alopecia you can remember in secondary syphilis. Okay, these are the two important findings. Primary, chancre will be there. Chancre is a painless ulcer. Chancre is a painless ulcer. Okay, secondary we are having moth-eaten alopecia. Tertiary syphilis we are having gammas. We are having gammas. What is gammas? Gammas are basically granulomas. Gammas are basically granulomas. You will be finding granulomas. Okay, you must have seen that images, right? Lata ko syphilis ho gaya tha. You can remember like that. So that is your secondary syphilis. That is your secondary syphilis. Okay. Now let's discuss about the next question. A 22-year-old female patient presented with the high-grade fever. Patient is having high-grade fever, confused state, purpuric rash will be there. Image is given here. Okay, CSF sample means they were talking about some kind of meningitis. Shows gram-negative diplococci. What would be the most common etiology? What could be the most common etiology? क्या हो सकता है यहाँ पर? What can be the cause, guys? What can be the cause? First of all, the diagnosis, it is a meningitis, and the answer will be Neisseria meningitis. It is a case of meningitis. Okay, you are having rash. Rash is already given, and rash is a feature you will be finding with Neisseria meningitis. Okay, next question, try to solve this one. A 18-year-old female present with a severe headache, high fever. Okay, 101. On examination, patient is having papilloedema. Patient is having again symptoms of nickel rigidity. Patient is having lakes of plasmid. This is another thing that is given here. Gram staining of the CSF is given below. This is the gram staining of the CSF. Causative organisms can be what? So basically gram staining is given. Gram staining, what you can appreciate from gram staining, what I've told you. If it is a, first of all, you need to identify, is it a gram positive bacteria or is it a gram negative bacteria? Okay, first of all, you will be identifying gram positive or gram negative. So if this one is gram positive or negative, it will be giving pink color because of safranin. So this is a gram negative bacteria. Gram negative bacteria, that would be giving pink color. So first of all, these are the out options. Okay, these are the out from the options. Okay, these are out from the options. Two options will be left. Now let's see, let me teach you how to identify. First, one more thing is there. They are looking in the forms of cocci. Okay, they will be looking in the forms of cocci. They are not bacilli, right? So this is how you can remember. Now let's see what are the important points about these two bacteria we will be discussing. One is Neisseria meningitis. Second one is your Neisseria gonorrhea. Gonorrhea will be causing gonorrhea. Meningitis is a diplococci. I've already told you about the culture media. Culture media is Thayer Martin media. Okay, and blood agar it will be showing gamma hemolysis. Pathogenesis, you will be finding Ciplo positive in both the cases. Okay, this one is also Ciplo positive. This one is also Ciplo positive. Ciplo is virulence factor. Virulence factor. Okay. Special features. This one is lens-shaped bacteria. Plasmid will be absent here, whereas plasmid will be present in the this one. This one will be having presence of plasmid. This one will be having presence of plasmid. What is plasmid? Plasmid is basically extracircular piece of DNA. Okay, meningococci, just remember in the name itself it will be having M and G, so it will be fermenting maltose and sugar. Okay, it will be fermenting glucose and maltose. Okay, it will be causing meningococcal meningitis. The important thing that you need to remember is these two complications. One is Waterhouse-Friderichsen syndrome. Second one is bilateral adrenal hemorrhagic necrosis. These are the two important things that you need to remember about this particular bacteria. For drug of choice, it was an old question they used to ask from PSM also. Okay, so drug of choice for carrier, we are giving ciprofloxacin because we cannot go to every carrier and give injection. Okay, those carriers which are coming to hospital, we will be giving ceftriaxone to them. Cases if they have diagnosed, the drug of choice will be penicillin. Apart from that, those people who are not diagnosed, we will be giving ceftriaxone. Okay, this one is your Neisseria gonorrhea. Gonorrhea will be having Thermartin, but apart from Thermartin, you can also use Newark agar. Okay, Ciplo is positive. They are kidney shaped. Okay, remember G we can write like that. So this is looking like a kidney, whereas M is looking like a lens. This one is your lens shaped bacteria. This is your lens shaped bacteria. This one is your kidney shaped bacteria. Both of them are diplococci. Okay, this one is only fermenting glucose because gonorrhea will be having G, it will not have M. Okay, so that will be fermenting glucose. Okay, the important things that we need to remember about gonorrhea, we have seen it will be causing acute urethritis. Most common cause of urethritis, that would be causing acute urethritis. Female, it will be causing cervicitis. We will be using kit number 1. Okay, in neonate, it was causing ophthalmia neonatorum. Okay, here also we need to remember again same two complication. One is ऊपर भी पानी वाली थी, that is Waterhouse prediction syndrome. Here we are having water can perineum. Water can perineum is what? Basically there are multiple fistulas present. Okay, that is water can perineum. Second thing, Fitz-Hugh-Curtis syndrome. Fitz-Hugh-Curtis syndrome, what is happening? You will be having you will be having adhesions, parahepatic adhesions you will be finding. These are your parahepatic adhesions. This is not coming clear. You will be having parahepatic adhesions. Okay, so this is about the Neisseria gonorrhea. Okay, diagnosis, you will be using swabs, and drug of choice will be ceftriaxone and azithromycin. Okay, drug of choice will be ceftriaxone and azithromycin. Try to solve this question. What is the probable diagnosis for a 40-year-old male, 40-year-old woman experiencing pain in her fingernail with the presence of pus in the nail fold? What is this? Is it a yellow nail syndrome? Is it a alopecia areata, or is it a psoriasis? What is it, guys? What is it? So whenever there is infection of the lateral nail fold, we call it alopecia. We call it paronychia. Guys. This is D. Yes, this is D. This is known as paronychia. And how you will treat this particular situation? Any kind of superficial infection, generally we are using amoxi. So we can use amoxi, and that was the question they have asked you. Drug also they have asked you. So that is the treatment of paronychia. If it is big paronychia, what we will be doing? We will be using 11 number blade. 11 number की blade लेनी है, incision लगाना है, सारा पस निकालना है, and then dressing करके we can give same drugs. Okay, so this is how we will be treating that. Next one is about what is the common association with the condition depicted below. This is your what? Oil drop sign. Oil drop sign is a feature of what? Psoriasis. Oil drop sign is a feature of psoriasis. Leukonychia striata. What is Leukonychia striata? You will be having white color lines. on the nails, right? That is Leukonychia striata. That is due to nutritional deficiencies. Okay. Pterygium of nail. Pterygium is a feature you will be finding with Lichen planus. And pitting of nails. Pitting of nails can be a feature of alopecia. Pitting of nails will be a feature of alopecia, guys. Pitting of nails will be a feature of alopecia. Look here. This is your alopecia areata. Very good, guys. This is alopecia areata. Alopecia areata means there will be hair loss from a particular area. It is an autoimmune condition. It is an autoimmune disease. Autoimmune disease will be there. What are the important features that you should be remembering about this particular disease? You will be finding easily pluckable hair. Let me give you. Easily pluckable hair will be there. One more thing, that is you will be finding a sign that is known as exclamation mark sign. You will be finding a specific sign that is known as exclamation mark sign. So you will be having this type of sign, that is exclamation mark sign, and around that exclamation mark sign, what will happen? You will be having some perifollicular hemorrhages, and that would be giving you a specific appearance. What is this appearance is known as? These are all exam questions, guys. Swarm of bee appearance. That is known as perifollicular hemorrhages. Okay, one phenomena that I have told you, that is white or gray hairs are spared. So we don't know the exact cause for this, but gray or white hairs are spared in alopecia areata. Okay, what kind of pitting you will be finding? You will be finding alopecia is in the head. I've told you that would be giving you superficial pitting. Superficial pitting. Okay, it will be superficial regular pitting. Okay, superficial regular pitting. Irregular pitting we have seen in the cases of where we have seen irregular pitting. Try to answer. Okay, pitting is this is your pitting. Basically areata will be having what kind of pitting? Superficial pitting. Psoriasis will be having deep pitting. Okay, these are the sign. These are basically all nail pathology in a slide. Okay, I have gathered all the important nail pathologies for you. Okay, so these are the all important nail pathologies that you have to study. Okay, so we are having this is known as oil drop sign. Oil drop sign is the most characteristic feature of which disease? That is your psoriasis. Thimble nails are the most common feature. Most common feature of which disease? Thimble nails are the most common feature of psoriasis. Okay, most common feature of psoriasis. Most common feature of psoriasis. Okay, now we will be discussing about other nail pathologies. First one is your clubbing. Clubbing is a feature you will be finding in the cases of hypoxia, guys. Hypoxic disorder, you will be finding clubbing. Okay, chronic hypoxic disorder, you will be finding clubbing. This is your koilonychia. Koilonychia is a feature you will be finding with Plummer-Vinson syndrome. What is the triad for Plummer-Vinson syndrome? Try to answer, guys. We are having some things. Try to answer. Okay, so what is Eldridge-Mees lines? These are basically horizontal lines that you will be finding in which poisoning? Arsenic poisoning. Okay, arsenic poisoning, you will be having this type of horizontal lines. Okay, this is your pterygium. When the proximal nail fold is dividing the nail into two part, that is your pterygium. And characteristic feature of lichen planus. Okay, this is your paronychia. Just now we have seen, and the treatment will be amoxy. We can give. Okay, these are your half nail sign or teres nail. What is the difference? You can see half nail will be having erythema. Here also half nail will be having erythema. How you will differentiate between half nail sign, Lindsay's sign, or teres nail? Just look here, guys. You are having ground glass opacities here. Ground glass opacities, you will be finding ground glass opacities here. Okay, teres nail is a feature you will be finding in pemphigus. Apart from that, in hepatic failure patient also. Okay, half nail sign or Lindsay's nail you will be finding in CRF patient. That is chronic renal failure patient. Okay, very good, Meher, Sadia. Okay, so what is the triad for Plummer-Vinson syndrome? We are having iron deficiency and anemia. We are having dysphagia, and we are having esophageal webs. Okay, right. Next we are having these are Buse lines. These are growing lines, growing and depressed lines. Whereas these are Muir-Case lines. These are, you can see, these are Muir-Case line. These are non-growing. These are non-growing, non-depressed lines. These are non-growing and non-depressed lines. Both of them are feature you will be finding in chronic illnesses. Okay, this is your ram's horn nail, or also you can also call it distorted nail. This is basically a distorted nail that you are seeing over here. So these are the important nail pathology. We are clubbing all of them together just before the examination. Okay, next, try to solve this particular question. A militant presents with the fever. Now the patient is presenting with the fever. Patient is having rash all over his body. Okay, rashes are there, which started in the trunk first. On examination, the rash was all over the body, sparing palms and soles. Along with the lice was noted. Your answer will be straight away lice caused disease, louse bone disease. What is that? Do you remember how to remember this? Let me make it a little simple for you. So we are having these things. Nowadays what is happening, they are not asking question from the starting chapter, because they already know you guys are studying the starting chapter. They are asking question from your ending chapters. Like they will be asking about the Legionella, they will be asking about Listeria, MRCS infection, like your Mycoplasma, your Rickettsial infection, okay, your Chlamydia, your Spirochete infection. So they are asking question from these slides. Okay, so how do we remember? We are having epidemic typhus, we are having endemic typhus. How do we remember? Let me give it a try. So we are having epidemic typhus, that is, you can remember, first of all you need to remember the causative agent. Remember, just speak with me, just like me. We are having louse, flea, tick, tick, mite, mite. Okay, we are having louse, flea, tick, tick, mite, mite. We are having louse, flea, tick, tick, mite, mite, right? So this is how we will be remembering the causative agent. Okay, second thing we can remember, how do we associate them? Epidemic will be, EP will be Kawasaki, and you can remember EPL. Okay, epidemic will be Kawasaki, and you can remember EPL. Okay, second one is you can remember ENT. Okay, second one you can remember ENT. Okay, endemic will be typhi. Third one, Rocky Mountain, R for Rocky, R for Rickettsy. India, you will be finding India in the corner. In the map, you will be finding India in the corner. So that is your Konori. India will be in the corner. And pox, remember, pox virus has some shape, right? We will be studying about the shape of the virus. So it will be having, in Hindi we call it akar. So it will be having some kind of akari, right? So pox will be akari. And lastly we are having scrub typhus, that would be causing that would be having Orencia shushugamushi. Okay, is this the way you can remember? Is it fine? So we are having epidemic. First of all, we need to remember louse, flea, tick, tick, mite, mite. Louse, flea, tick, tick, mite, mite. Then we are having, we can remember EPL. EPL means what? Epidemic will be having Kawasaki. Okay, epidemic will be having Kawasaki. Endemic will be having typhi. R for rickettsia, that would be Rickettsy. Indian will be Kona. India will be in the Kona. Pox will be in the Akar. Okay, and lastly we are having scrub typhus, that would be your Orencia shushugamushi. Next one that we need to see, a patient was diagnosed with TB. Okay, this one kar loge aise question. I think you will be able to do this type of question. So that is louse, flea, tick, tick, mite, mite. So louse will be Rickettsial Kawasaki. Just one more time, please try to see it. Okay, a patient was diagnosed with TB, and while testing for resistance, he was found to be resistant to isoniazid. Look here, isoniazid resistant, rifampicin resistant, amikacin resistant, levoflox resistant. Which type of TB is this? Try to answer. Thank you guys. Just try to answer. Okay, in the last we can have a chit chat. Okay, first we will be studying. Okay, so we are having, we can rule out the option. Generally try to rule out the option, but here we already know what is the MDR TB. Try to answer what is MDR TB. The TB which is resistant to rifampicin or isoniazid, that is your MDR TB. What is XDR? XDR means what? Rifampicin plus isoniazid is there. Along with that, any of the fluoroquinolone, any of the injectable. What is the injectable that is given here? That is amikacin. Amikacin is a type of aminoglycoside. So amikacin is resistant. Apart from that, any fluoroquinolone, that is your levofloxacin. Levofloxacin is also resistant over here, right? So this is what is XDR TB. Okay, XDR TB. Okay, what is TDR also? Let me discuss what is TDR. Total drug resistance TB. That means nothing is working. Now, if nothing is working, what will happen? If nothing is working, we can use certain drugs. These are your bedaquiline. We are having pretomanide. So these are the drugs we will be using in the total drug resistant TB. Okay, TDR TB. Okay, TDR TB. Okay, next thing about Mycobacterium. Mycobacterium is the causative agent for TB. It will be causing what? It will be causing TB. First thing, it is an obligate aerobe. Okay, obligate aerobe, that means it will be present in the upper part of the lungs, because there will be high oxygenation. V/Q ratio will be, V/Q ratio, there will be high oxygenation, will be more above, right? So there will be high oxygenation. You will be having, it will be 20% acid fast. 5% acid fast will be lepra. 5% will be lepra. This one is 20% acid fast. Lab diagnosis, what you will be doing, you will be taking the sputum and you will be putting the sputum on the Zaden staining. You will be putting the sputum on the culture media. Okay. What is this particular culture media? This is your LJ media. This is Lowenstein-Jensen media. And how do you sterilize this particular culture media? Try to answer, my dear doctors, please answer me. How do you sterilize this particular culture media? Okay, so Jaden staining, you will be having mycolic acid, you will be having all those steps. Ultimately, you will be having blue background, and these are the bacilli that you are finding. These are the bacilli, red bacilli, because it will be having mycolic acid. They are binding with the dye. Okay, they are binding with the dye. What is the dye that we are using? We are using carbol fusion dye. Carbol fusion will be giving red color. Okay, so this is your algae media. You will be finding luxuriant growth, eugonic colonies. Okay, rough, tough and buff colonies. And algae media, I've not got the answer, guys. Algae media and LSS media, what we were doing for algae and LSS, we were doing what? We were doing inspeciation, guys. We were doing inspeciation for both of them, right? So what are the different tests we can do? These are the important one-liners you have to remember. CB naught we are doing for RPOB gene. RPOB means rifampicin. It will be telling us about the rifampicin. Nowadays we can do gene expert. I am waiting for your answer, not autoclaving. Autoclaving is done for all the culture media except LJ and LSS. LJ and LSS, we are having another thing, that is inspeciation, guys. That is inspeciation. Okay. So we are having gene expert. We are using PCR, IS6110 gene, IGRA, interferon gamma release assay. We are having CFP10 or ESET6. We are having line probe assay, that is used for MDR or XDR TB. We need to identify for drug resistant TB. We can do line probe assay. Okay. Fluorescent method, I've already told you, we are using it for central institute or big institutions. We are using auramine rhodamine dye. Tuberculin test, we are injecting 0.1 ml on the flexor aspect of the arm, and then we will be checking for the induration after some time, right? After some days, right? So that is the basic story. Now from the derma part, we are having lupus vulgaris. The meaning of vulgaris in the derma will be most common. Here, this is the most common type of skin TB. This is the most common type of skin TB. Lupus vulgaris is what? Most common type of skin TB. What is scroflocium? Okay, and there is a feature you will be finding central scarring. Central scarring is a feature here. Okay, central clearing is a feature you will be finding with tinea infection. Okay, this is your scrofloderma. This is the second most common cutaneous TB. It will be involving your lymph nodes in the children, TB in children. That is your scrofloderma. Okay, and this is your diascopy. This test is known as diascopy. Here you will be finding apple jelly nodule. Here you will be finding what kind of nodules? You will be finding apple jelly nodules. Okay, try to identify this particular case. The below given image is characteristically seen in which of the following type of leprosy? This image is seen in which of the following type of leprosy? Is it a borderline leprosy? Is it a lepromatous leprosy? Is it a histoid leprosy, tuberculoid? What is that? So leprosy is caused by, let's learn first, then you will be answering. So leprosy is caused by Mycobacterium leprae. How much acid fast is this? This is 5% acid fast, है ना? And one more thing you need to remember, this will not follow Koch postulate. What is Koch postulate? Robert Koch ने क्या कहा था? They will be growing under culture media. But this one is not growing under culture media. So what is the thing where we will be growing this particular bacteria? Try to answer. Okay, till then we are having two types of leprosy. Bachcho, we are having paucibacillary, we are having multibacillary. Paucibacillary, bachcho, we will be having 1 to 5 lesions. Okay, if there are 1 to 5 lesions, we call it pauci. If there are more than 5 lesions, we call it multibacillary leprosy. Okay, nerve involvement, if I talk about, if 0 nerve is involved, that is a paucibacillary. If 1 to 2 nerves are involved, that is a multibacillary leprosy. Pauci treatment will be given for how much time? Treatment will be given for 6 months. Same drugs will be there. Here the treatment will be given for 12 months. Here the treatment will be given for 12 months. What are the drugs that we will be using? We are using rifampicin, clofazimine, and dapsone. D for dapsone we are using daily. Okay, clofazimine also coming with C, is coming with D, so both of them we are giving daily. Okay, that is 50 mg we are giving daily. Okay, and these two things, 600 and 300, they are high doses. The patient will be getting in the hospital every month. The patient will be getting in the hospital. Yes, this disease is also known as Hansen's disease. This disease is also known as Hansen's disease. You will be having hypoanesthetic patches on the body. Okay, you will be having hypoanesthetic patches. Okay, hypoanesthetic patches. Just a minute, guys. Right. So you will be having hypoanesthetic patches. Okay. So rifampicin, clofazimine, and dapsone are the drugs that we will be using. Now we will be discussing about the lepra reaction. What is the lepra reaction? For example, a patient is coming to you. You are giving some drugs. Okay. You are giving some drugs. Now what will happen? Try to understand. Now what will happen when the patient is taking rifampicin, clofazimine, dapsone? What will happen to the patient? Patient will be having some kind of reactions, right? So when the patient is having some kind of reaction, these are known as lepra reaction. Okay, so should we continue the treatment or we should stop the treatment because of these reactions? Okay, and the patient will be having erythema, patient will be having nodosum, patient will be having multiple things, nodules, painful nodules will be there. So what we need to do? Should we need to continue the treatment or we should stop the treatment? We should be continuing the treatment. We are having two types of lepra reaction. One is type 1 lepra reaction, another bachcho type 2 lepra reaction. Type 1 is a type 4 hypersensitivity reaction. You just need to make it 5. Okay, so type 1 will be type 4 hypersensitivity, type 2 will be type 3 hypersensitivity reaction. Okay, so in type 1, what you will be doing, you will be continuing the treatment. Along with that, you will be adding what? Steroid will be doing what? Decreasing the immunity, would ultimately leading to decrease in the reaction. Okay, so lepra reaction will be subsided. Okay, in type 2 lepra reaction, you can use steroids. Along with the steroid, one question that they have asked you multiple times, that is your thalidomide. One drug that you can also use, that is your thalidomide. And what is the specific side effect of thalidomide? Everyone try to answer. What is the side effect that you will be finding with thalidomide? And the classification that we are using for leprosy is known as Ridley-Joplin classification. Ridley-Joplin classification. Ridley-Joplin classification. The side effect of thalidomide, tell me guys. Ridley-Joplin classification, we are dividing the leprosy into TT type, BT type, BB type, BL, and LL. TT, BT, BB, BL, or LL. These are the types of leprosy we are dividing. Very good. That is phacomelia. Phacomelia is the side effect. Phacomelia. Okay, C-limb deformity will be there in the patient. Okay, so these are the things in the children, right? So BT type of leprosy. BT कौन देता है? BT कौन देता है? People in India will be giving BT, right? Okay, second thing, satellite किसने launch किया? We have recently launched a satellite, remember? So satellite lesions and most common in India. If they ask you, your answer will be BT type of leprosy. Okay, BT type of leprosy. Okay, second one, BB type of leprosy. BB क्या करती है? Saucer धुलवाती है. So you can remember inverted saucer appearances. Inverted saucer shaped lesions you will be finding. Okay, और geographical lesion, हमेशा घूमने की बात है. Geographical lesions will be there. Okay, so these are the two things. All of us are students, right? So geographical lesions will be there. Geographical lesions or inverted saucer shaped appearance you will be finding. Most common in India, satellite will be there. LL will be having a specific appearance that is known as leonine facies. Leonine facies. And that was the question. That was the question that you have to see. That was the question that has been asked. Try to answer now. Now, is it a leonine facies? or something else. So this is a lepromatous leprosy, and can you appreciate the face is like a lion face? Okay, this is known as leonine faces. Leonine faces. I have not gathered the images of BT type of leprosy. You will be having satellite lesion. This is the, look here, this is the lesion, this is the normal lesion. Around the lesion we are having some more lesions. This is known as satellite lesion, or satellite is the type, satellite is the example for satellite. What satellite lesion you are finding in which type of leprosy? Satellite किसका गया था? BT. Satellite will be BT, and most common in India is also BT type of leprosy. Okay, BV I have told you, geographical and inverted saucer appearance. Okay, LL we have already discussed. These are the important ones you have to remember. Okay, now try to solve this question. A veterinarian whatever is that, okay, developed an ulcer with a central black scar over the forearm as shown in the image. Okay, so basically this is a story. There is a veterinary doctor. Okay, so he has developed some kind of a scar over the skin. Now you need to identify what can be the possible cause of this particular thing. What can be the cause? Is it Pseudomonas aeruginosa? Is it Yersinia pestis? Is it your Bacillus anthracis or Francisella tularemia? So tularensis will be causing a disease known as tularemia. This will be causing a disease known as tularemia. Yes, this is known as malignant pustule. This is also known as malignant pustule. What is the meaning of malignant? Is it a malignant means it is a cancerous disease or something else? Yes, I'm getting good answers. So, sir, this cannot be Yersinia pestis, right? Yersinia pestis will be causing what? It will be causing plague. Okay, Pseudomonas, generally it will be having such different kind of pigments. Pseudomonas will be having pyoverdine, pyocyanin. So that is concerned with the pigments. So this one cannot be the answer. Okay, tularemia is a different entity. Our answer will be Bacillus anthracis. Bacillus anthracis. Now let's see the important points that you have to remember about Bacillus anthracis. All of the organisms, capsulated organisms will be having capsule made up of what? Capsule is made up of polysaccharide. For all other organisms, capsule is made up of polysaccharide. Here the capsule is made up of polypeptide. Okay, and the reaction that we are seeing here is known as McFadden's reaction. कौन सी reaction होती है? McFadden's reaction. Spores can be used as a bioterrorist weapon, and the appearance. Just remember, just as I say, just remember like that. Suppose there is a miss means there is a madam. You can remember she is having Medusa head appearance. Her appearance of the head will be she is having Medusa head appearance. She is having inverted fir tree dress. She is wearing a dress which is inverted fir tree like dress. Okay, she is having string of pearl मोतियों की माला पहनी हुई है. She is having string of pearl. Okay, she is having bamboo stick on one hand. Okay, and she is having a plate. Okay, she is having a plate. Plate is a culture media, right? She is having a plate in one hand, another hand she is having a bamboo stick. Okay, and in the plate we are having a tripartite toxin. तीन चीजें होंगी उस टॉक्सिन के अंदर. Three things will be there. EPL, edema factor. Second one is labile factor will be there. EPL will be there. Protective factor, edema factor, will be there, and L for lethal factor will be there. Okay, so it is a tripartite toxin. उस plate के अंदर. So what do you have to remember? Remember again, what you have to remember? There is a miss. She is having Medusa head appearance, inverted fir tree like dress. She is having string of pearl appearance. Apart from that, in one hand she is having bamboo stick, on another hand she is having a plate. In the plate she is having a tripartite toxin. What is that tripartite toxin? It will be having three factor: edema factor, protective factor, and lethal factor. Three factors will be there. So that is the important appearances that you have to remember about the anthracis. Okay, this is the inverted fir tree appearance. This is your bamboo stick appearance. You will be having this thing. This is known as malignant pustule. Three things it can do in the patient. Three things can happen. First, those people who are carrying the animals on their back, they will be having malignant pustule. This is known as Hyde-Porter's disease. ये घसीट के लाते हैं animals को. This is known as Hyde-Porter's disease. Second one are your wool sorters, those people who are sorting the wool, they will be having pulmonary anthrax. And how we can treat this? With the help of a thing that is known as formication. Okay, we are treating the wool with 2%. We are treating the wool with the formaldehyde. Okay, we will be treating the wool. Okay, next we are having is intestinal anthrax. We will be having Ascoli thermoprecipitation test. You know what is happening? Those people who are eating wild ingestion of the animals. Okay, wild animals they are eating without improper cooking. So those patients will be having this type of anthrax that is known as Ascoli thermoprecipitation test. Okay, we will be treating the wool with formaldehyde, and this is known as duckering. Guys. Okay, formaldehyde we are using, that is known as duckering. Okay, next we are having is Bacillus cereus. Remember, C for cereus, it is concerned with Chinese fried rice. It is concerned with Chinese fried rice, and the incubation period of Chinese fried rice, this thing and Staph aureus will be same, right? So Bacillus cereus will be having two strains. One is emetic. Emetic means emesis. Emesis means what? Vomiting. Okay. Another strain is diarrheal strain. So emesis will be seen in 1 to 6 hours. Okay, that is after Chinese fried rice. It will be increasing cyclic AMP. Okay. Second, diarrheal strain, it will be showing symptoms 8 to 16 hours, meat or milk ingestion, and it will be increasing cyclic GMP. These are the Bacillus cereus. Okay. Next thing, try to solve this one. A 24-year-old male patient present with scaly lesions over the body, as shown below. In the image, no other associated symptoms are present. What is this? What is the diagnosis? What is the diagnosis here? What do you think? Is it a lichen planus? No, we already know. Till now, what we have studied, we are utilizing that lichen planus will be having sir pterygium, plain, purple, polygonal, pruritic papules should be there. So it cannot be that. What is seborrheic dermatitis? Simple wordings. If I say seborrheic dermatitis is a type of dandruff. Okay, dandruff that you are having is nothing but your seborrheic dermatitis. Okay, atopic dermatitis. It is also related with asthma like things. Okay, so nothing like that. Okay, so this is your pityriasis rosea, and the meaning of pityriasis, what I have told you, the meaning of pityriasis is scaling. And now I think you must be knowing scaling is a secondary change. Guys. It is a secondary change. You will be finding secondary change. You will be finding after some kind of a trauma. Basically, what will happen? There will be desquamation of stratum corneum. Okay, so this is your pityriasis rosea. You will be having red color marks. The first patch that is developed is known as mother patch or herald patch. These are the basic history that has been given multiple times. Mother patch, herald patch. Then what will happen? After that, you will be having development of another patches in a specific pattern. This is known as Christmas tree pattern. Or fir tree pattern. Okay, what are the scales that you will be finding here? Scales are important. You will be finding collar like scale. You will be finding which kind of scale? Collar rate of scale. You will be finding collar rate of scale. Okay, or cigarette paper scaling. Cigarette paper scale or collar rate of scale. Let me summarize all the different types of scaling here itself. Okay, so what we have seen till now: silver scaling, silver white scaling. Silver white scaling is a feature of, try to answer, I am asking, try to answer. Okay, we have seen fish like scaling. We have already seen fish like scaling. Okay, where do you see fish like scaling? We are having greasy scales. Okay, these are basically secondary lesions. Okay, we are having greasy scales. We are having brainy scales in micropath, in micro and derma. We are having brainy scales. We are also having rice grain scales. And we are having this collar rate of scales. Okay, scales are basically desquamation of stratum corneum. Okay, desquamation of stratum corneum. Silver white scale we have seen in psoriasis. Psoriasis is the cause. Fish like scaling we have seen the ichthyosis. Next thing, greasy scale or briny scale is a feature you will be finding in, greasy scale is a feature you will be finding in a disease known as seborrheic dermatitis. Seborrheic dermatitis, that is basically dandruff. In dandruff you will be finding seborrheic dandruff, you will be finding greasy scales, okay, or briny or rice grain scale you will be finding in pityriasis versicolor. Pityriasis versicolor. Versicolor will be having different findings. What are the findings you will be finding in versicolor? That would be present on the trunk, okay. Versicolor means different color, different color will be there. Hyperpigmented patches will be there, okay. What are other things you will be doing? Wood lamp examination you will be doing, you will be putting it in the SD agar. What you will be finding? You will be having there fried egg colonies you will be finding. Apart from that, you will be finding spaghetti and meatball appearance, okay. Spaghetti and meatball appearance. These are the important things that you have to remember. These are the important things that you have to remember. And the treatment, we can give selenium sulfides. Treatment, we can give azoles, we can give selenium sulfide also, okay. Try to solve this one. A 4-year-old boy presents with the complaint of fever. This is the I think this is the diphtheria question, okay. So basically all the symptoms that are given over here, they are the symptoms of diphtheria. Membrane will be having diphtheria, okay. So when you try to remove all those things, we have already seen. So these are the symptoms of diphtheria, okay. This one they are talking about, try to see, this one they are talking about the central AC system, okay, air condition, okay. They are talking about air condition. Second thing, they are talking about BCA. BCA is buffer charcoal yeast extract, okay. So BCA is the thing that we have already seen with Legionella, okay. Legionella, centralized AC system, and this one is the second thing, okay. Mycoplasma and pneumococcus, how you will differentiate? Brucella patient will be having fever, patient will be having rash, and patient will be having hepatosplenomegaly. Patient will be having fever, rash, and hepatosplenomegaly, okay. This one is mycoplasma and pneumococcus, that would be causing pneumonia. We are having two types of pneumonia. We are having one is walking pneumonia, that you will be finding with mycoplasma. Walking pneumonia means what? The patient will not be having symptoms, more symptoms, okay. In COVID-19, what was there? In COVID-19, when you are going for checking up, when you are doing a HR-CT scan, what you are finding? In a HR-CT scan, you are finding 70% of the lungs are already damaged, okay, but there is no symptom. The patient is sitting with you and they are laughing and all those things are happening, just a common cold, okay. So these are your walking pneumonia, also known as atypical pneumonia. Atypical pneumonia, and the drug of choice for walking pneumonia, atypical pneumonia, will be azithromycin. Why we are not giving amoxi, why we are not giving ceftriaxone? Because this mycoplasma do not have cell wall, so we are using the drug macrolide, okay. This is a macrolide. In COVID-19 also we use macrolide, that is azithromycin. Second one is your pneumococcus. Pneumococcal pneumonia, we have already seen. Pneumococcus will be causing typical type of pneumonia. That means the patient will be having lobar pneumonia. The patient will be having less symptoms. Patient will be having less symptoms, and the patient will be admitted in the hospital, okay. Patient will be present in hospital, so he will be having less symptom, but the patient will be present in the hospital. Today we are done with the time, guys, because this channel will be having another class, so I think we are left with some vesiculobullous disorder. These are important ones, okay. DIF you should be knowing. This is the DIF. Let me do it complete. In 2 minutes I will be explaining, in case if you understand. Okay, so let me give you orientation. This is your epidermis, this is your dermis, okay. This is your basement membrane zone. This is your basement membrane zone. What is happening here? We are having IgG or C3 deposit, and this disease is known as bullous pemphigoid. Basement membrane zone will be having hemidesmosomal proteins like BPAG1 or BPAG2. They are present over here, BPAG1 or BPAG2. So there will be deposition of antibodies. This is your bullous pemphigoid, okay. In pemphigus group of disorder, what will happen? You will be having two keratinocytes. These are two keratinocytes. They are binded together with the help of desmosomes, right? So whenever these are your retiridges, try to identify. These are your retiridges. These are the part of epidermis which are going into dermis, and these are your dermal papilla. These are your dermal papilla. Now what is happening? You will be having these keratinocytes. These keratinocytes are binded together with the help of desmosomes, and here again IgG is getting deposited. So this is the antibody that is getting deposited, and this is known as fishnet type of pattern you will be seeing in the cases of pemphigus group of disorder. Okay, lastly we are having linear IgA. How you will differentiate? Linear IgA will be again depositing in the basement membrane zone, but antibodies that we are having is IgA antibody. And last one, that is your dermal papilla. Just look here. This is your dermal papilla, part of epidermis which is part of dermis which is going into epidermis. This is your dermal papilla, and here we are having micro abscess, that is known as papillary. Dermal papilla will be having papillary tip microabscess. That is a feature you will be finding in dermatitis herpetiformis. Again you can see herpetiformis will be means, herpeti means you will be having extensor surface will be having grouped vesicle. Every minute is important guys. Extensor surface will be having grouped vesicle. Okay, so this is what you need to see. I will be sending it. These are the important question you have to see. That is your copper penny bodies. Okay, this one is chromoblastomycosis. You have to see these questions. They are multiple times asked question, candida. Okay, so I will be sending the PDF, and thank you so much for all the patience that you have maintained throughout the session. Okay, you can always connect with me on my Instagram, on my Telegram, and we will be having other sessions also. So thank you so much for all the patience, and we will be meeting again. All the very best for your exam guys. Those of you who are giving exam, all the very best for your exam. I really want you will be coming on the next side of the fence really soon. Okay, best wishes guys. Thank you.